I don't know if Sue is with the rest of the team. Perhaps you could let us know, Sue.
Hi, good morning.
Good morning, Sue.
Hello.
You've got the board here. I won't go through individual introductions today because it will take 10 minutes. But when we hopefully have the chance to ask questions and things, I'll ask people to introduce themselves as they ask a question, if that's all right, Sue.
Absolutely. I am sorry, it is just me on Teams. I think Roselda's trying to join from Ashford, who's the medical matron, and Al was going to join. He's working on Willow Ward this morning. So yes, I'd be delighted. I've got some slides which I think have been shared with you, but I'm hopefully going to try and share them now, just to go through, and this is just about the Wentworth story and end of life care at Ashford and St Peter's. Yeah.
Yep, great. We're looking forward to it, Sue.
All right.
All yours. We can see it.
You can see it. So this story is about the delivery of end-of-life care in 2020, and end-of-life care is very much governed. Can you see that? Is that moving on, Andy?
It's not moved on yet. Yes, it's moved now.
Great. Care of the dying adult is very much governed by national guidance, NICE guidance, and this really came about in 2015, and after a fairly challenging time around the Liverpool Care Pathway and then subsequently Gosport. The NICE guidance highlights the importance of compassionate individualised care and has some fairly clear indicators about what should be delivered in care of the dying. And really these are the recognition, most importantly, of when a person may be entering the last days of life, effective communication, shared decision making, providing individualised care, maintaining hydration, pharmacological and non-pharmacological interventions, and anticipatory prescribing. And our challenge at Ashford and St Peter's was delivering this compassionate and excellent end of life during a fairly challenging time. So, you know, to coin a phrase, we had one chance to get it right. So during the COVID pandemic, we had significant challenges to provide excellent end-of-life care for our patients. And we adopted a personalised approach according to the needs of the individual and the service. So we continued a 7-day specialist palliative care service. We implemented a bereavement support service with our spiritual care team. We introduced very clear guidance for respiratory, including weaning doses of anticipatory drugs. We implemented end-of-life care visiting, and we started to commence a model of end-of-life care delivery. Initially, this was end-of-life care beds at the Woking Nuffield. We went into collaboration with the Woking Nuffield, and we had direct transfers over to the Woking Nuffield for end-of-life care. And then subsequently, we developed a direct transfer model with Woking Hospice. And the most important thing is we also took over beds at the Runnymede, which we delivered the Wentworth model, end-of-life care on Wentworth. So we took 12 beds on Wentworth Ward at the Runnymede Hospital. We identified Ashford and St Peter's staff who had skills in caring for the dying patients, and they were transferred to work on Wentworth. We took this hub of nurses and doctors and healthcare assistants and housekeepers, and we looked at the education and the competencies for all of the staff. And we were very well supported by the division and by the hospital. We had an identified medical matron, we had an OT, we had registered nurses, HCAs, and we utilised our doctors who are on the specialist palliative care rotation. And we also utilised our CNSs who would do their reviews over on Wentworth ward. We had specialist palliative care advice 7 days a week, 24-hour on call, and we had palliative medicine consultant ward rounds weekly over there. And any medical reviews outside of that time were escalated to our on-call medics. The nursing staff, the supportive and palliative care nursing staff, did daily patient reviews over there. So it was a really very well supported and very effective model. So the way it worked was that all patients were reviewed by specialist palliative care at Ashford and St Peter's, and a management plan was put in place before transfer to Wentworth. All the patients were COVID negative, and we facilitated end-of-life care visiting over there. We developed with our medical nursing colleagues an individualised care delivery pack, or our priorities pack, and we had adhered to the nursing quality indicators, perfect ward, etc. Part of that was ensuring daily communication with family or significant other, and we very much, as part of that management plan and care delivery, was the preferred place of care and preferred place of death. And this was really well worked with a direct transfer model to Woking Hospice. And this really is probably really outlines the effectiveness of that model, and hence the reason I brought the standards for delivery of excellent end-of-life care at the beginning was around, we did an audit of the care delivery on Wentworth against those standards, and I think that, you know, this slide probably speaks for itself. That 90% of the patients that were transferred over there had a recognition of dying. There was individualised care plan, and for those that weren't, it wasn't about the fact that they weren't recognised as dying. It was the fact that they weren't dying. So 100% of the families were contacted and had daily communication. In the notes of all the patients that were transferred to Wentworth, there was evidence of shared decision making. From a hydration and nutrition point of view, 100% of the patients had a daily oral intake recording, and etc. 100% of the patients had symptom observation charts, pharmacological and non-pharmacological reporting, and most importantly, we didn't have any pressure sores, and we didn't have any complaints either, which is really rather nice. And the feedback was always. We were always delighted to have such positive feedback around all of our staff, which really was hugely appreciated by the staff that worked over there, because actually, as you can see from the previous slide, you can see that in that period of time, there were 610 admissions and there were 293 deaths. And the average length of stay was 6 days. So the interventions and the care delivery was intense, and it was always really positive to receive such good feedback. Thank you. That's the end of my slides.
Thank you, Sue. If you want to stop sharing, then we can. Slides are still up.
Oh, are they? Sorry.
Teams has been wonderful today, isn't it?
Is that me back? I closed my slide down.
No,
No, you're sharing your desktop, Sue.
Oh.
So you have to go to the top and stop sharing.
That's it.
All right. Thank you.
Excellent. So I'm going to open up, Sue, to questions on that. So who's got a question for Sue? Got James first.
Thanks, Chair. Thanks, Sue. It was a great, really nice to see that presentation. But I thought in some ways it didn't do justice to the amount of change and adaptation that you guys went through during COVID. Because the first wave, as you say, we moved. In the early days, we thought we needed to get everything off site, and that was what we were told to do nationally, and that's what we did. And you guys championed that really by going over to Woking, and then the work with the hospice, and then through the second wave when we identified the beds in the Runnymede. So it was a key part of enabling the organisation to ready itself for a COVID response. And I just want to sort of emphasise that because it was so important. It was a key thing for us around readying the rest of the hospital and to take such care of this really important group of patients that we were still looking after. So I just wanted to draw that out, Sue, because it really was, for me, it was the beacon of how services changed and responded at a tremendous pace. We would normally take months and months. In fact, we are taking months to do other change that I see around other hospitals and community hospitals. We did this in days, literally days, both times. So just drawing that out, and also just to say thank you.
Thank you.
Sorry, Jane.
Thank you, Sue. That was a really interesting presentation, and as James has said, a great initiative. I've got a couple of questions. One is, I presume this linked with people's desire that maybe they wanted to die at home. So I presume the discussions were led and was that facilitate? That's one question. Was that facilitated so people had that choice? Secondly, there are around 200 patients who didn't die. I'm just interested in, were they in the right place? Were they sent to the right ward, or what was the plan for them? And if it was so well evaluated, which is absolutely brilliant, and it sounds like people really valued it, I just wonder, as a wider system, why we not continued it. Was there a reason why? Because it has been so valuable. We're no longer there. Maybe somebody could answer that for me. And my final one is, only 10% were transferred with a nursing plan. I'm just interested as to why that was so low.
Yeah. So, and I think this probably comes back to what James was saying. So I think preferred place of care and preferred place of death absolutely is part of that management plan when we moved patients to another location, but actually is fundamental to that assessment anyway. I think just even from a specialist palliative care point of view, our intervention with patients is normally something like is also about 4 to 6 days, and that is taking into account preferred place of care and preferred place of death. You're absolutely right. Preferred place of care, preferred place of death at home. I think in our patient group is quite low to get people home. And that's just more of a valuation of the data that we have, and we can see where people are going to. So preferred place of death at home is low in this area. I think the nursing care plan was that when we initially, as James so rightly said, we started off on our feet. We're very lucky to have very clear guidance, individualised care. We're working against the basis for the individual patient. But I think when we first started off, the unit was very much nurse run. So patients were going there with nursing care plans, and as the I guess as things became more challenging, we had doctors, and our rotational doctors rotated over onto Wentworth, and that then changed the criteria of the patients that went over there. And just going back, and I didn't, because I think Teresa was very much about, you know, we need to look and evaluate the effectiveness of this model and how we're going to move things forward. But we have moved things forward. We have now got some specialist palliative care, end of life care beds on Willow Ward. There are 16 beds on Willow Ward, and we have taken the Wentworth model and the SOP, and we are implementing that on Willow currently. So yeah, thank you, Jane, for that.
Thank you. Thank you.
Thank you. If you don't know Sue, can I remind you to just introduce yourselves? Fran.
Hi Sue, I'm Fran Davis. I'm non-exec director, starting tomorrow actually with Ashford and St Peters, so very new to the organisation. And I think my question was a bit similar to Jane's. I don't know what the model's been at Ashford and St Peters, but in the last few years, palliative care beds have tended to be put onto wards. You know, dedicated palliative care wards have tended not to happen in hospitals. And it just strikes me there in terms of it's such a successful model, whether you're going back to having maybe dedicated palliative care beds, which you've just answered. And I suppose from your perspective, listening to the way that you've described the care, it sounds like there was a really high degree of nursing and professional satisfaction as well as patient satisfaction. I just wondered on your observations and, you know, that positive thing around now that you have demonstrated perhaps the value of having dedicated beds. So it was really building on what Jane was saying and the learning, I suppose, from this and as we go forward, but you've probably answered that already.
I mean, I think as a nurse, end of life care, I mean, it's always been coined, hasn't it, as the litmus test of all care. And I think as a nurse to be able to deliver, you know, compassionate end of life care is absolutely very, very rewarding, but also quite challenging. And yes, I think we've got some excellent nurses that are very committed to delivering that. And when we opened the beds on Willow, we absolutely saw that there are, you know, nurses that are delighted to work in that environment.
I guess it's always the balance though about de-skilling on other wards if you don't have sufficient. So it is a challenge, but I'm really pleased to hear that you've sort of taken that learning from this, as Jane said, going forward.
Thanks, Fran. Andrew.
Thanks, Susan, for that. I thought that was really helpful and really interesting, really. I'm a clergyman by background and profession, so I've often, like some of your colleagues, had to deal with people in quite challenging circumstances around dying. And I'm also very aware that the assisted dying bill, private members bill by Baroness Meacher, is about to come soon through the House of Lords, and some of us have seen this before, and I'm very aware of the work that Baroness Laura Finlay, who's a real expert in Wales actually on palliative care, and Tanny Gray Thompson actually takes quite a strong line on all of this. And I suppose it's in my mind at the moment because my mother's 103 next week, and that she often worries that she's a burden to us, which she's not, but actually I'm very aware of that issue around all of this. So I'd be very interested, one is coming if there was an opportunity to see what you're doing, because I think the arguments around palliative care need to be made and understood, because otherwise people like me worry, and like Laura and others, about the unintended consequences of some of the things that are proposed. It all seems very simple and straightforward, but I know from experience it isn't. But I'm willing to listen to people's points of view on all of this actually, because it's quite complicated. So your experience and knowledge in this space, I would find interesting actually, because I suppose my responsibility is to try and make sure factual, detailed discussion happens about the real case, rather than just spins and line in a newspaper, because these things matter. And of course, the unintended consequences around the medical profession, which David and others, what do we let loose here? Is it good or bad? There's a proper discussion about all of that. The detail matters. So I just make that point because I think it's a rather important thing coming up and has implications for what you're talking about.
Yeah, I think you're right. It's very interesting. I think maybe it's something we could perhaps look at, if you'd be so kind as to perhaps come and maybe have that discussion on our end of life care committee as well at Ashford and St Peters, because I think, yes, it does have huge implications for us as healthcare professionals, and also about that delivery. And the last thing we want is for people to feel a burden.
Yes.
What I think what this model and the model of care that we're hoping to continue on Willow is about people's respecting people's individual wishes and priorities.
So no, thank you, Suzanne. It would be very interesting if you invite me. We could try and make, because it'd be very interesting to listen to you and your colleagues who are at the front edge of all of this.
Thank you.
Thank you.
I'm sure we could do that. So David.
Yeah, I mean, I think a lot of people have said some of the things that I just wanted to say to you, Sue. James, I mean, this happened at an extraordinary time, and I think the presentation is absolutely brilliant, but it doesn't capture quite what a change you made to the delivery in the model. And we had lots of discussions about this, and you did mention just now about nursing care and how nursing care took a front step here, and we'd had lots of discussions about that, Sue. But it's not great nursing care. It was great care you delivered and great medicine in terms of dealing. And I think what you underplay here is your role was extraordinary leadership from you, Sue. Was amazing, actually. Thank you.
Thanks, David. Chris.
Hi, Sue. It's Chris Ketley here. I'm on the quality committee with Jane and Fran soon, and also chair the integrated digital committee. I mean, I really was taken by what you've done, and thank you, and fantastic what you and your team have achieved. This is probably not something you maybe immediately answer, or you may be, but it just can, you did this at a time when there were people dying and not having the sort of care that you gave to the non-COVID patients. Is there anything that you picked up and learnt from what happened to the COVID patients and their families versus what you do now with the non-COVID, when people in normal palliative care? Are there any lessons to be learned there? I don't know whether that's a reasonable question or not.
I think so I think the difficult, isn't it? So the standards for recognizing dying and delivering care in the last days of life are firmly regulated and firmly outlined in guidance. And I think coming back, and it's thank you very much for the feedback regarding the role, but it is very, very clear what is expected of excellent end of life care, and that's our role to deliver that. I think during the pandemic, so if you're asking whether the delivery around the NICE guidance to COVID and non-COVID, I'm going to say that it was the same, just in a bigger volume, in a much more challenging environment, because having shared decision making and when family contact was so minimal is just very challenging virtually. So I think yes, absolutely, there were some real differences. I think probably what it has taught us is the importance of family engagement, significant other, making sure that we're talking to the right person and having that daily communication with families. And I think that's been a huge lesson out of that. And obviously that's something that we've continued now, irrelevant of what illness, of what diagnosis of dying, around that communication and communicating to the right people in a timely way every day.
Yeah, that's great. It's one day digital can enable that in some way as well, a bit like the face-to-face consultations.
Yes, and I think those are absolutely areas for huge improvement, because I think technology can absolutely support that.
Thank you.
Okay, we're starting to run a little short of time, but Simon and Suzanne. Simon first.
Thanks, Sue, for the presentation. Really helpful. I was just left a little bit uncertain about the kind of system-wide future of palliative care. Obviously, we've been trying to support work in hospice during the pandemic. Obviously, care at home has always been pushed a lot, and yet we've ended up with a unit that's bigger than ever in many ways, despite those kind of directions. So it's just trying to understand that context and strategically where palliative care should be heading.
Yeah, thank you. So I think it's really key, and I think end of life care is one of those areas that is truly collaborative. And yes, you're right. Why have we got a specialist palliative care or a palliative care ward in a hospital and end of life care beds? And I think the answer comes back to the fact that, you know, the Wentworth model showed, because we have the evaluation for it, that we can absolutely discharge to preferred place of care and probably facilitate that in a more timely way. But there are many of our patients that we see that it is completely inappropriate to move them out of hospital, and their place of death is going to be hospital, and we need to make that as good as we possibly can. So I think developing beds here is not about keeping patients in hospital. It's about enabling their preferred place of care and death.
Okay, thank you.
Suzanne.
Thank you, Sue. I mean, it's a great presentation, and thank you for your leadership through that time, and well, before that time, during that time, and after that time, because I know you continue to be a real influence on how we approach this as an organisation, and I know your compassion will shine through all of your work. My question was not dissimilar to Simon's in a way. I think I heard you say that the majority of patients in our care prefer to die in hospital, but I'm just wanted to clarify if I'd misunderstood that.
No, we assess everybody's preferred place of death. Unfortunately, many of our patients, a percentage of our patients, are not fit for transfer, not able to be transferred, but where we've identified preferred place of care or death, we will support and enable that transfer, which is why working collaboratively with the hospices is great. And particularly the direct transfer model to Woking was fantastic, because we were able to move people within sort of 24 hours. So no.
So if that's the case, then I suppose not for now, but I suppose I'd want to understand, is that a bit of our practice that needs improving in the wider organisation, which I think was what Fran was pointing to. If we centralise that expertise, then we may lose that early opportunity to kind of have that conversation with the family and take that person to their preferred place earlier. Is that why we're late? Or I mean, clearly I'm aware there are patients where sometimes that just isn't going to happen. So that would be maybe something that I'd want to understand, that we were kind of looking to in terms of developing the skills and capabilities of the whole team across the rest of the organisation. And I think the system point is really well made, and we need to continue to work as we have been, and supporting, I think, particularly the care at home piece. I think people often feel anxious that they'll be abandoned with a dying relative, and so even if it were their preferred place, they may opt for the other.
Absolutely.
But thank you for everything you've done.
Thank you very much.
So I'll give the last question or comment to David.
Well, it was a bit along that. I mean, I think, Sue, what we also found during this time was that it looks like the numbers of people who are dying have increased. We know more about them, but actually they were dotted around all over the hospital, being randomly investigated and not looked after in the right way. And I think that's kind of what I see. And one of the juxtapositions, which I think is interesting for people to know, is Sue spends a lot of her time with ITU, trying to decision make over a patient. So that's where the education and the drive needs to be done. And I think for reassurance as well is, I mean, the hospice, we've never had more transfers to the hospice in a timely way. There was a time when that fantastic facility was half empty, and now it's full. So I think I think that shows that we have to recognise people when they're dying earlier on in the process, and that's where medicine has gone a bit offline. And I think this is actually helping uncover that a bit more. And that question about what do we learn and about communication with family early on. I mean, we've seen it in lots of places that dotted through. We've seen it in the medical examiner's report and their audit. We've also seen it in the cardiac arrest audit about where people have cardiac arrest, which all point to discussions happening earlier and people understanding what trajectory people are on, right, really, rather than travelling in hope along the wrong path, really.
Thanks, David. And just we've run out of time, as we always do, but I tell you that Sue, that we regard kind of staff and patient stories at board as absolutely vital in keeping us in touch with the front line, be it frontline patient experience or frontline staff experience. So thank you ever so much for coming. Sadly, your colleagues couldn't, but we absolutely understand the pressures that are on at the moment. And like Suzanne said, I think on behalf of the board, I'd really like to thank you for all the brilliant work that you have done during the pandemic and you are continuing to do. So thank you.
I will pass that on. Thank you very much. Thank you for having me.
Thank you.
Bye-bye. Bye-bye.
Bye.
Bye, Sue. Bye.
Lots of things to ponder, I think, about that, and I think Andrew's thing around the act that's going through at the moment as well gives us a lot of points to ponder, I think, and it'd be very useful for you, Andrew, I think, having that input from the front line, because there's nothing like real detail rather than people's sometimes misplaced passions.
No, exactly. And just a thing to David, I find it helpful, Dave, to get your view on the implications for the medical profession and the tradition, because, you know, these small things can have major impacts on cultures and behaviours, but not now. But at some point, I'd be interested in your thoughts on that.
Okay, thank you. So we'll move on now, and thank you for arranging that, Louise. That's great. Move on to the rest of the board meeting. So welcome to the board meeting on 30th September. Anybody, any declarations of interest in any items that are on the agenda, please? No? Okay, good. Apologies, Liz?
Apologies from Dami Adideo and from Andrea Lewis, but Jackie Reese is deputising for Andrea, the chief nurse.
Okay, thank you. And I think welcome, Chris Kane. I think this is your first board meeting. You observed one, but I think this is your official first board meeting. So welcome, Chris, and welcome, Fran, observing today, non-executive, whilst Dami is away on maternity leave from tomorrow. So,
thank you.
Thank you.
Welcome to you both. Okay, so we'll now move on to the minutes, and sorry, welcome to Jackie as well, so, who's obviously here for Andrea. We'll move on to the minutes and we'll take any corrections on the minutes. So anything on page 1? Two. 3. Wow, 14 pages a minute here. 4. 5. 6. Suzanne?
Thanks, Andy. Item 76 2020, which runs over about 4 pages. Towards the bottom where we refer to the Bourne Education Trust. Just point of accuracy, really, it's not a local charity. Bourne Education Trust runs many of our local schools. Yes. It's the trust that runs the schools. So I don't know, we just need to reword that to be accurate.
Okay, thank you, got that. So page 7. 8. 9, 10, 11, 12, 13, and 14. So with no other comments, with that one clarification, I think that was probably the right way of putting that. We'll take those as accurate minutes. Thank you. Well done, Liz. And we'll move on to the action log. So for September, that was to come back in September that I had asked that consideration be given to reinstating the walkabout programme, but within IPC guidelines. And I think we were going to get some verbal feedback on that. I guess especially as the IPC changes that the government has announced this week. So who's going to feedback on that?
Andy, I can feed back, and I apologise if you can hear builders just in the background. So Andrea and I met to discuss the walkabouts, and Andrea's feeling, given that we were continuing to see a level of transmission within the community and in patients, that it would be sensible to start the walkabouts from October/November time. We've also had some sort of updated and very helpful guidance shared with us by a member of our team, which could give us a very helpful template to update the format of those walkabouts. So Andrew and I are working through that, and very shortly members will be receiving some comms either from myself or Liz to actually start getting the dates set up. So it is a work in progress. Apologies for the noise.
Okay, thank you. So you'll be communicating with the execs and non-execs on walkabouts. Okay, all right, thank you. And there are no other open actions. So we'll move on, and we'll move on to my report is next. So apologies for those of you who've seen that there were two versions of my report. The reason for this was quite straightforward. I obviously couldn't put a report into the open forum as it's an open board report until we'd reached the point where we could announce Suzanne's moving on with Wales, and we'd agreed that on the Monday. So hence the only difference between the two reports is that paragraph that I have inserted. But that's the reason for the amendment to the report. So moving on to the report itself, and I couldn't start in any other place really, but that we have hugely mixed emotions. That we're really happy for you, Suzanne, that you have got such a great role coming up but not till February with Cardiff and the Vale. To say that there'll be massive shoes to fill would be a real understatement, and to say that we are grateful for what you've done for the Trust for the last 11 years would also be a massive understatement, to be honest. But we'll have time to do these things over the next 4 months. But just to put on record that you continue to be a great Chief Executive, and we really appreciate you. And we know that you will add greatly to the NHS Wales delivery. And having spoken to your new chair and warned him all about you, he is really looking forward to the experience of working with you, as I have for the last 4 years. Well,
Thank you, Andy. Thank you. Mixed emotions felt at this end of that conversation as well. And
yes.
Yeah, it's been quite an arduous week from an emotional side of things with the announcement and so on. So, but Yeah, I really appreciate your feedback, everybody, and your support. Thank you.
Thank you. And you know, from the rest of the report, I mean, Suzanne will cover it. Just how busy we continue to be, and the impact of the pressures, particularly on our staff. But I just want to again put on record the work they're doing is fabulous under very, very difficult conditions. And yes, sometimes people get a little short. Sometimes people get short with each other or whatever. But actually, the amount of work that we're getting through in so many different areas is a real testament to our staff. I think I wanted to highlight the staff awards ceremony, and those who were there. It was just brilliant to be back face to face, and it was enlivened, shall I say, by the Panto flash mob joining us to sing us in and sing us out, and singing and dancing. That was really, really good. And thank you really to David Rennie, captain of tennis at Wentworth Golf Club, because he did a great job comparing, and that's no easy matter. Just the pronunciation of names, very, very tough, and he did it all with excellent humour and told his own story as well, which is a great story for Ashford St Peters, of how his life was saved in the hospital. So that was just a great event. And also nice to see Ruth May, Chief Nursing Officer for England, here, and I know Suzanne's covering that as well in her report. But more to the point, her actually presenting 2 silver awards to both Fiona Holly and Hannah Spencer, and we're doing well on those silver awards. So that was very, very good to see. And in terms of my own inputs, very much splitting the time between the system activities and visibility and the trust. As one of several people asked to talk to the 3 candidates for the ICS chair position. I know David was another one, and Jack Wagstaff was another. So we are continuing to have input, and I think the chair candidates will be announced perhaps even today, actually, the winning candidate. And the other thing, very interesting risk workshop at system level, and I was really pleased to see that during that workshop, kudos was given to Marcine's work and input to that. So well done, Marcine. I was really, really pleased that they appreciated your expertise in that area, and I know it's not been particularly easy. The rest of the things I will take as read, but I'm very happy to take any questions anybody may have. Okay. All right. In which case, we will then move on, and we'll move on to Suzanne's report. Suzanne.
Thanks, Andy. So I'm starting, if you like, at the back of this report, so page 12 to 13, because that's where the summary comes together. In many ways, the story isn't very different from the last time we reflected on this position. It's clear that if you look at the sort of risks as calculated and scored, that the risk we're bearing continues to be predominantly in our people and around our people objective, and a strengthening risk around the financial position. And I think that's right. The fidelity of the sort of high level risk scoring probably doesn't reveal some of the emerging risks that we're seeing around the quality and safety of patient care, and particularly the experience of the management and processing of their care and needs. And I think we do need to be careful around that. And we had quite a detailed conversation at the Quality of Care Committee and the People Committee about how to articulate those risks and reflect it as accurately and with as great sort of fidelity and sensitivity to those sort of elements, if you like. So it's a complicated picture, isn't it? And so probably the easiest sort of way to take you through it, I'm sure you've read the report, is to use the summary at the back. And clearly we've got our non-executive chairs of the relevant subcommittees with us, and invite them to comment around their particular areas. I think in terms of the quality of care, and I think it's been referred to already in many ways. So you'll have heard people refer to the wave 3, and it's not so much a wave as a plateau, but it has persisted through the summer, and we certainly have and continue to see fluctuating but relatively high rates of community transmission of the virus, and fluctuating, but in the numbers of sort of 20, 30, 10, it's fluctuating the number of inpatients, but clearly providing care to them does present us with a challenge when the pathways are all very busy, and all of the IPC requirements around those pathways need to be met to keep those patients and our team safe. But what is good to see is that it very much does look as though the kind of benefit of the vaccination is that the link between requiring hospital admission at all, and indeed certainly in terms of critical care, has been broken. Very low numbers of patients requiring critical care, and certainly our intelligence indicates that the vast majority of patients in that scenario have not been vaccinated, if they're requiring critical care. But nevertheless, that's a burden that has sustained at a relatively high level through the summer, and that is set against the backdrop of the continued really unprecedented demand on the urgent emergency care pathway, and the needs for the recovery to be sustained in terms of addressing the backlogs of patients we have for planned care and diagnostics really do continue to stretch the team in quite an extraordinary way, and certainly nothing I've ever experienced in my career. I think the team are doing brilliant work to both mitigate those risks, but also to identify and surface them in an organisation of such scale and complexity. Being able to identify where those risks are manifesting is part of the challenge in many ways, and I think they're doing a good job there. But I think what I'm trying to sort of weave through this report is a sense that the burden of that on the team and the stretch continue to kind of chip away at the organisation's both cultural basis and also our team well-being and resilience. And I think we do see that emerging in some of the kind of communication we now see from patients, the tone of it, the length of it. I mean, David and I were reflecting, some of the communications we receive from patients now appear to be providing them with therapy, the opportunity to write with a great deal of detail and distress at length about their issues, is unusual. It is unusual, and often the issues are more of an administrative process aspect and communication and confusion than actually the care issues itself. So it is concerning to see that. And obviously we will continue to do all of the work, and James can speak at great length about work to improve the outpatient pathway and the booking team work, etc., etc. I think in terms of our people, yes, we've worked really hard through the summer to get people away for some leave. We thought that was really important, but that's also brought its own challenges, because certainly through the back end of July and August, it actually became a burden in terms of the management of the team and the availability of colleagues to deploy. But I think it was worth it. What I would say is, probably certainly for the predominant members of the team who are at the front line, responding to patients, delivering care, that a week or two away from the organisation on the back of an 18-month intense is not enough. And whilst it might have provided some light relief, I doubt very much it will have addressed the issue. So we need to not be in the place where we think, well, excellent, everybody's had a summer break, so we've reset. We haven't. The financial risks, I think are covered quite clearly in the report. The underlying deficit position that's being driven by our very necessary response to the operational burden remains significant, and without clarity around how that's going to be compensated for, in terms of a clear arrangement for the second half of the year, it's very difficult to make a judgment on where we'll end at the end of the year. But it is clear that will be a challenging position. But I think our risk appetite and our approach to responding to those operational challenges are clear, and where we need to make investment to deliver the best care, we will continue to do that. But it does come with a significant financial risk. I think from a digital perspective, clearly, we've seen this delay with Surrey Safe Care, which was as a result of a technical challenge, which has now been resolved, but it has taken us off our timeline. And whilst initially I was very disappointed, I think the reality is it does create some time in our programme. So what we have to sort of work with the team on is take that opportunity and make real use of it. So our go live will now come in March next year, which will take the pressure off through the Christmas period, which obviously was a concern, and does create more time to do more detailed planning and deepen the exposure to the team of the training and the skills necessary. So in some ways, you might say we're going to turn a difficulty into a silver lining, and that's always the ambition. And from a point of view of collaboration, well, we continue to do a huge amount of collaboration across, every aspect, and we're going to spend time this afternoon in Strategic Change Committee considering some of the detail. I think the thing that's sort of coming through is the focus on the provider collaboratives and the work that we need to do around that. And I think there's an appetite in the system and engagement, but we need to turn that appetite and engagement into real practical initiatives and organisational collaborations that deliver and respond to this challenge. And I think that is the real challenge here. So I will invite the non-executive chairs to make any additions they want to, and or take questions before I move on to part 2.
Thank you, Suzanne. Do you want to start with Merrick? Any comments to make?
Well, not really. As I said, actually, in the earlier meeting, I think the summary is a very impressive summary of a lot of moving parts. I think probably just one point is that the volumes and work levels in the hospital exceed anything seen before, even during the pandemic, because the pandemic at its peak had a different shape, which is quite remarkable in terms of the performance of the staff and the pressures on them. And of course, as Suzanne said, that's costing money, and these things all come together at some point. We don't know how yet.
Thank you, Merrick. Jane?
Thank you. I think I would really support the summary that Suzanne has brought. Certainly that was our feeling at the Quality Committee. And I think her point around some of the feedback that patients are providing now where they are dissatisfied, I think is also a reflection of the wider community stress. I mean, because everybody's been through a really difficult time, so all of us are very sensitive. And, we're not just patients, our relatives are sensitized as well. And I think the problem is all of us are in a little bit of an anxious time because we don't seem to have moved forward as quickly as we would hope to through this pandemic. So I think being mindful of everyone's tensions, I really do feel for the staff at the moment. And I think Suzanne is, I think, very honest in the fact that we're not out of this. We've got quite a lot of work to do in many different areas.
Thank you, Jane. Marcin, with your Audit Risk Committee, and given Dami's not here, if you want to make any people type comments as well, because you only recently left that committee.
Yeah, it just goes to show that I'm just listening to Suzanne, that you can see the storm. And I don't know how you cope every day, but it's so impressive. But you can see that it all ranges from people. I mean, I think people's at the core of all of it, and how they speak and what they do, and even if showing up. So that mirrors with what we were doing on the People Committee. So I think that's right. In terms of the Audit Committee, it's interesting. This year we've got 14 internal audit reviews, and most are now out in the operations in terms of internal controls. And I think that speaks to what Suzanne talks about, is actually getting some of those processes right, because actually if we smooth out processes and they are simple and they are effective, then some of these other issues can go away. So I'm pleased to see that we're aligning that agenda, but we still have a lot to do, as Suzanne knows.
Thanks, Marcin. Chris, with the digital?
Yeah, I mean, I share Suzanne. I think we all do, her disappointment that we couldn't get Surrey Safe Care over the line in December. But, you know, we probably bought some very valuable time. Progress is being made now. The focus is on usual acceptance testing to get that. And that's going to be quite intensive. And then really moving towards the training of staff on the systems. And I think we're still delighted that we'll be doing a single instance launch with Royal Surrey on the 7th of March. So hoping that there's not going to be any further massive hitches, but things now progress to plan.
Thank you. Chris, I know you haven't chaired a strategic change yet, so it's quite unfair for me to ask, but if you wanted to make any comments, do feel free.
I think my initial impressions is huge kudos to the management group. Having had a couple of weeks under my belt, I'm just staggered by what's being done on so many levels, and I think everybody has already made the point that you're dealing with such enormous complexity. It's just truly staggering. So I'm looking forward to learning more in the weeks ahead.
Thanks, Chris. And just so people are clear, while Dami is on maternity leave, Aaron will be taking over as chair of the People Committee. So we will not be chairless on the People Committee. Right, Andrew.
Just a reflection really on yours and Suzanne's very helpful comments. And I think Suzanne's absolutely right. The focus on delivery really matters. But as a person who turned up at the awards ceremony, which Louise organised, I thought it was a really great event, actually. And it was really great to sit on a table with a patient who'd nearly died. That next to him was the nurse who saved him, but dressed in normal clothes, not in nursing gear. And he was dressed, and actually there was something about that was very powerful. And I do wonder whether we make the most of these events in the sense of, because sometimes hospitals can seem quite removed from the community, and how do we get a proper dialogue with a community we're now ever more engaging with in the processes we're involved in here, which I think is very exciting. And I just wonder whether on some patients, because it's about creating gossip over time, you should invite to those round tables, and round tables are the right way to do it, and those events, some former patients and others who've been through this journey with the people who've cared for them, but not dressed in nursing uniform, but just real people meeting, so that the general public starts to understand what a hospital and the interface with patients, the community, that these are just people really doing their best, as Chris has just said, in quite complicated circumstances. Just sometimes simple little things like that create a whole different kind of relationship over time. And certainly if you start to then use the technology of YouTube and other things around stories and people, because we need understanding in the general public about the things we're hearing today, but maybe the outside world doesn't fully understand the complexities of what's in play. It's just a simple thing, but I do think Louise did a great job there. And it's a sort of, the clue was on my table, I felt, and it was just interesting listening to the dialogue between the patient and the nurse.
And I think that's a great idea, Andrew. And just bringing, in inverted commas, outsiders into that, because I was conscious that the two people that were prime movers in Nourish Our Nurses were there. And they both really, I think, Chris, you were sitting with them, weren't you? And, they really, really enjoyed it and came up with some ideas, for us, for how the community could support those ideas, the events going forward. So, so you're just to widen your point, really, to bring sort of interested people. I mean, we always have mayors and things there, but together is really quite. So Suzanne, back to you. Oh, sorry, Louise.
Louise, I think.
Yeah, sorry, I'll be brief. It was just, I'm just reflecting on that and on sort of my week this week. So obviously, for those of you on the People Committee, you'll have seen the paper that I wrote and presented last week around culture transformation. We talked already a lot about culture. We dedicated a whole hour at our last tech talking about culture and what we need to do to try and shift that. And our focus tends to be on the negative feedback that we've had. Meeting with the wellbeing ambassadors this week and talking to them, and again them sharing their feedback around issues of resilience, as Suzanne has already pointed to. And then I came across a couple of emails in my inbox when I was trying to search for something from the summer, and it was an email that was sent to David, I think, or James, because Suzanne was on leave, and it was about a nurse at the end of her tether who was going to leave the organisation because she couldn't get accommodation for her family. And it was a really difficult email to read. So having reread it a couple of months later, I went back to my team and said, were we able to resolve this? And my accommodation manager came back and went, oh yeah, we've got the person, family accommodation on site. They've managed to relocate their family from overseas. They're really happy. And nobody knew that because we don't close the loop in terms of stories. So what we see as executive team all the time is where it goes wrong, and what we very rarely see is when we manage to resolve that, or when it goes right. Yeah. So I agree entirely with Andrew in terms of how do we continue to share those stories so that we learn, but also we create more opportunities to positively reflect rather than just reflecting on it when it goes wrong. And I'm not sure I know the answer to that, but we will continue to think about how we do that.
Thanks, Louise. That's very insightful.
Great point. Yeah.
Suzanne, back to you.
Thank you. I mean, just to say, the executives are leading all of this complexity. I'm just presenting the paper, and I think it's, I know we'll come to the detailed reports that cover off the sort of portfolios, but I think, I just want to be clear that this is a summation of their great leadership and work across so much. And I think that's just important to note here, and we'll come to their reports, but yeah, this is a summation of their great leadership and work, and all of our team clearly. So in terms of part 2 of the report, this is what I call my show and tell, and I'll pick up a few areas, but you might want to sort of ask any questions when we've done. So important, I think, to just point to the continuing infection control and prevention work that's going on in the organisation. Andrea's done a refresh of the visiting video, etc. And I know that there was sort of a publicity earlier in the week about changes to those rules. I think what I would say is that's guidance to us to consider before we change any of our rules. So we haven't changed any of our approach at this point. David and Andrea and the rest of the team will need to review that. And I think it will need to continually be reviewed in the context of the rates of infection locally, and they are on their way up at the moment again. So carefully does it, I think is what I would say, and so I think that's important. I'll refer to the healing arts piece. Marcine and I have had a great set of email exchanges this week because I really enjoyed her video. It was great work. And I think it is so important to hold on to these things, because these are the things that will support our team resilience and support our patients feel calm in what can feel very intense environments. So it is really important, whether that be inside the hospital or outside of the hospital. So I think we really welcome your re-energising this work, Marcine, and keen to see that sort of continuing to develop. Optivo housing, it's really good. If you stand upstairs on the back corridor, you can look out and see that coming together. And I feel enormous pride around all of that, the opportunity to provide really high quality housing to our colleagues on site, and it's really going to, it's coming together. They look like houses now. They even have windows, so really important that we kind of just say, well done to the team putting that together in the midst of all of this. Those things are still happening. And finally, then the digital piece, I think it's really good to see in here, we're obsessed with Surrey Safe Care, rightly so. It's an enormous investment and we need to make sure that delivers for us. But there is still a good deal of work going on outside of that. other kinds of systems being brought to bear, and again testament to the team being able to get across all of that. So the report refers to the Badgernet implementation in NICU and Dawn for our rheumatology department, to name but a couple, which have been really have gone well, and the team are really benefiting from the opportunity to use those systems. And lastly then, just we keep going with the moving stuff out of the hospital, and there you see the next iteration and the work with Woking Leisure and the physiotherapy services being put into Woking. So, that mission and work continues apace. And I will stop there. Oh, last thing, actually, sorry. Going back to David Rennie, I just want to do a shout out for the walk at Wentworth on Sunday. I think essentially David and all of the sort of people who are participating from the Wentworth side, that they will walk a marathon on Sunday. They're going to do, starting at 7 in the morning, they'll have walked enough laps by 5 in the afternoon to have walked a marathon distance. And we've encouraged Team ASPH to come along, and they don't have to do the whole marathon. They could just do one lap, bring the dog, bring the children. I won't be doing the whole marathon, but I will certainly be doing the afternoon marathon, and I might even be timing my attendance for the promised champagne tea at 5:15. So, bit of encouragement there. But yeah, I think that's really good. And David and his colleagues have got great plans for their focus on supporting us through the rest of this year. And I think it's a really good opportunity. What better way to kind of connect, to make, to your point, Andrew and Louise, is to connect the community with our team than a walk on a Sunday afternoon and a chat around beautiful landscape. So I'm hoping it isn't going to be raining. Happy to take any questions.
Thanks, Suzanne. Questions for Suzanne? No.
Andy?
Marcine.
Could I just give a shout out to one of our projects that links to the presentation from Susan on the palliative care is our biggest project. We're looking at scoping, getting designers in. It's called a time garden, where we'll allow families of dying patients and the patients themselves or staff to talk about how to deal with dying patients. And we've found the location, and we've got a plan, and I'm very excited about it. So we're already linking into what we can do to increase an environment that is actually more attuned to what's needed for the families and the visitors.
Right.
Right. I think my only, as I said yesterday, I think my only guidance on that would be that we don't put it somewhere where we then destroy it later. Because we have got a bit of a track record of doing wonderful things, and then operational considerations come in, and then we have to take it away again. So I think we just need some careful thinking about that.
Oh dear. Okay, the site's been chosen, so well, maybe we can share with you our ideas.
All right.
Thank you, Marcine.
Thank you.
Thank you. Okay, if there are no more questions for Suzanne, we will move on to the next section, which is the quality and safety section. And the first is the quality report, and I'm going to ask Jane to give a forward to that before we ask Jackie to speak to it.
Thank you. We received this at the committee last week, and the areas that we particularly focused on were firstly patient experience. One of the areas we discussed was that we still have relatively low response rates, which was disappointing. Our target is 20%, we're at 3.8% at the moment, and we had quite a discussion around how meaningful is the feedback when we have such low numbers, and the work that we're going to do to try and improve that and engage our staff and our patients in providing that really valuable feedback. So that was a key focus for us. And certainly with the divisional reports which we had presented at the committee, that was equally a challenge because the numbers are even smaller there. So actually it really makes it very difficult to make meaningful summaries from the feedback which we received in those reports. So we need to work with the divisions on that, and Jackie and her team are committed to doing that, as is Charlotte and her team. And infection control, there's a new target which Jackie will talk to in the report, which means that we need to reflect that in our board assurance framework target, which Jackie will talk to, but that was something we discussed. We recognise that there are still some delays in our structured judgment reviews when patients die in our care, and we were pleased to see some extra resources being put into that. Some excellent work by the bereavement officers and their teams in linking with families, but we still are behind the curve on doing the actual structured judgment reviews, which is something the committee has been concerned about for some time. We had quite a bit of a discussion around the concerns we had around outpatients and some of the patients that hadn't been appointed, but we had a clear process described by James and the team around how patients have been triaged, how the waiting lists were now lower, and that all the patients had had a clinical review and they were being appointed. So that was quite good assurance around that, although we do still have some people obviously waiting because of capacity. Maternity, we're making good progress on the Octon. We've completed 2, we've got 5 in progress, and we had some discussion around the National Advocate role, and actually our Chief Executive was very directive in saying, why are we waiting for the national guidance? Let's just sort out ourselves a National Advocate, in that we need to really get that person in place, which we're keen to do. So we will obviously work with the national guidance, but we don't have a definitive role descriptor yet, but that doesn't mean we can't start making progress in progressing that work to get that person in place. So that was really helpful to have that steer. And we've done very well with our student midwife recruitment, so we've got a very high level going to be joining us, which is absolutely excellent work, and Louise and her team have been working with the head of midwifery doing that, so that's really brilliant. So we're really looking forward to when they come online next month now, so that'll be brilliant. Thank you. I'm going to hand over to Jackie now.
Thank you, Jane. Jackie.
Thank you. So I'll start from the top then. So this report covers July and August, and we've already discussed in detail, I think, the extra demands in the system, and of course that's and that we've had sickness in our patient experience team, which has had an effect on the sickness, the timeliness of responses from the divisions, and our ability to meet our 95% response target. It was 78%, I think, when we last looked. So you know, we recognise this dip in performance, and we understand the reasons why. And with the team, the sickness is reduced now in the team, and we've got an improvement. You know, we're aiming to get back up to as high as we possibly can, given the context that we're in. The themes in the complaints of treatment in care, they're fairly similar as they usually are: communication, diagnosis and discharge for this period. And the PALs, again, we've spoken about appointment queries. They're the majority of the inquiries, and there's a lot of work going on, and things like you know, what's the content of the letters, confusing patients turning up for virtual, in person for virtuals. It's just that they're misinterpreting some of the letters, and I know there's a group working at revamping the letters to make sure that they add clarity for the patient receiving them. Focusing on the good things, though, our viewpoint system is particularly good at capturing compliments, and there's plenty of them, and the report highlights a lot of compliments, and we've just put a few in there. I'm sure I'll take them as read across the organisation, and that, you know, that piece is working well. But picking up Jane's point about our response rate overall for the friends and family test, we were at 3.2% and 3.8% in July and August this time. So what are we doing about that? So it's not the outpatients so much that's an issue, because we've got SMS texting asking them about, you know, what their experience like going out to the patients. It's the inpatient piece that needs further work, and there's also a piece around staff engagement, because obviously in order to get the responses whilst they're inpatients and actually passing through the actual hospital, they have to be given the opportunity. So we've got a number of handheld devices, and we've increased the number available to patients in the ward areas. We've done some engagement with the staff in those areas, and
interesting, I think it might have been Andy that raised the point, is that we have an entrance point in the hospital where we have volunteers standing, and we have a feedback capture device sitting right next door to that person, and that we need to make the most of our volunteers, you know, because often most people, when they're coming through the front door, they're doing their masks and perfectly, and so there's a possibility there for doing the two things as people are going out, and asking them could they put in their reflections about their experience. So you know, the team have completely revamped the whole of the system. In fact, in July and August, it was we've added different questions to make sure that we're asking the right questions of our patients according to our strategy vision, and we, you know, we'll continue to push on with that. Always open to suggestions, but we'll watch this space with that piece. So I'll bring you to Healing Arts now, and I know we've spoken a lot about that, but I must say we've had a very positive time around Healing Arts after a period of slow progress because of all the restrictions around COVID. The programme relaunched by Marcine this month with her lovely video. You know, we'll walk around in Chelsea and Westminster, although the report says we were planning that. We actually did that, and that was a revelation. It's just a wonderful place as exemplar site for the inclusion of healing arts throughout its organisation, supported by and involving the local community. So we got lots of ideas. We had new contacts, we made new networks, new ways of doing things, and I think it was a really positive visit, and that informed our trust walkabout, didn't it, Marcine, where we spent some time walking through the hospital with the curator from the Lightbox in Woking, Marcine, our head of patient experience. A group of us went round to really get a feel for where we could make impact in the organisation with healing arts, rather than necessarily doing you know, a sort of a try and do everything approach. We came to the conclusion that we would probably focus on 3 clear projects, one of them being the Time Garden that Marcine's which I think we're most excited about, and obviously we have some funding for that and a place. I better not say where we think it should be, Marcine, because until we get the right permission, but the suggested location would be absolutely perfect for it. So really lots of work going forward now, and we've got the fire in our bellies, there's no doubt about that. So medication safety, we're on track with that. There's not a lot of extra to say about that. It's just the team continue to work well at responding to any issues around medication. And then the infection prevention control section. I want to explain to you the new NHS contract for gram-negative infections was recently published, and we previously set our quality priority at a 3% reduction in gram-negative infections for the year, but the national contract has suggested 5%, so that's stretched us a little bit more. It's sort of a few extra numbers, but in the current context, you know, that can make a difference as to whether we achieve our targets. We have included those. We've adjusted all the numbers and trajectories already to a 5% reduction for E. coli, Klebsiella, and Pseudomonas. And we've got, but I mean, as Andrew will tell you, we have a strong infection prevention control strategy, so we will respond as best we possibly can to that. So following a relatively long period of time without hospital COVID, we had an outbreak recently in August in the plateau wave, as Suzanne has described it. After lifting restrictions from lockdown, we had a full ward of COVID patients and 2 outbreaks, one on Swan and one on Wordsworth, and they accounted for the hospital-acquired cases reported in August. And we've had no further outbreaks since. So SSIs, you can see from the graphs in the report, the cesarean section is showing sustained improvements, and one of the key interventions is that seems to support that improvement is the introduction of warming blankets in theatres. And what really good progress has been made by the team. We now have baseline data and improvement trajectory for all of our surgical interventions. So we're in a place now where we know we're asking whether we're following up our patients. We've got good surveillance and scrutiny of cases, and we've got a programme of interventions and support in the clinical field to drive forward our improvements around SSIs going forward. So this time, antimicrobial stewardship audit, the biannual audit was published, and overall there's a little change with prescribing prevalence. It remains at similar levels to previous audits. Within that's run by our pharmacy team. There are a number of recommendations around that to further develop the stewardship guidelines and to build in the stewardship requirements into the Surrey Safe Care, which is probably going to be the most impactful, I feel. Sepsis. So we set ourselves a target of improving our sepsis compliance for the Sepsis 6, and at the early part of the year we took some baseline data to understand where we were and set out an approach to deal with the highest areas where we were lacking in compliance, and this was focused on blood cultures in ED. So we're in the process, we've put some training in place and identified the fact that there's been a dearth of training for nurses in taking and responding to blood cultures, and some competencies have been put in place and support for us to improve on that. There's also Jane, it was raised in the Quality of Care Committee that there was also work required on the lactate levels, which was also an area of non-compliance. And in speaking to the team after the Quality of Care, they are going to include that in our lactate levels in the re-audit and push forward on that as their next improvement focus. So the deaths in hospital, I think Jane's already summarised that actually for us. We're not really outlying. It's just these SJRs and the early mortality reviews that is challenging us. But the good news is that we interviewed for the mortality improvement lead for that service this week, and we've got one further interview next week, and the hope is that we'll appoint from those interviews fairly soon. So and that person will be focusing on improving and engaging with staff to move those targets forward. Moving on to pressure ulcers, they are just very disappointed this time. The first category 4 pressure ulcer reported in this organisation for a very, very long time. Just to give you a little bit of context, it was a collar pressure ulcer. A patient had an unstable C1, C2 neck fracture, which required a rigid neck collar, and ended up suffering a grade 4 pressure ulcer. The team have checked with the manufacturer, wanted to they try to understand why it happened. They asked the manufacturer to see if there had been any modifications made to the collars that we usually use. Nothing was identified. They discussed across the trauma network to see whether or not there was something that we weren't doing. Was our practice not at the right standard? There's nothing that obvious that there was nothing that was new to them. So the focus of the TVN team for the organisation was to work closely and put in a new detailed care bundle around the care of neck collars, and that includes dermal pads, use of silicone tape, skin care beneath the collar, and collar care guidance. So there's been a lot of work to avoid that happening again. Just quickly, I do feel I've been talking a long time actually. Falls, we set ourselves tight targets from the outset, and unfortunately for our moderate and for severe falls we have missed our target so far, but we've got our recently appointed falls prevention lead is working hard, has now really got into the flow of the new post and is working hard with the teams to improve our approach to falls. The main focus is she's offering a lot of ward-based hot debriefs to speak with the staff about when a patient falls, what might have gone wrong, and a real focus on repeating a risk assessment, a falls risk assessment on patients when their condition changes or they're transferred from one environment to another, because this can often be an issue with the falls. Another point is that the MUST scores have dipped slightly, but we feel that this is the pressures of the high patient demand and some ward move issues, but they're aware of what the issues are and they're focusing with the ward teams to improve those MUST scores. And our repeated falls is also showing improvement. Just one last Ockenden report. We're doing quite well, and as Jane has mentioned, that Suzanne has given us the green light to just go ahead and implement actions without the national permission, and I've got no doubt that in terms of the midwifery advocate standard, that person that we will find the right person and be setting that standard probably above what's required nationally. So that's it in a nutshell. Please, any questions? I do hope I've managed to cover the majority.
Thank you, Jackie. Questions for Jackie? David.
It's not a question actually, because Jackie's done a great job in giving all the detail. I think it's just drawing your attention to the surgical site infection and the trajectories. So if you compare what the trajectories are, we are quite high compared to the national levels. But I would say that's because the surveillance that we've now put in the trust in actually identifying, contacting patients and understand what the true rate is really good now. And I think, as Jackie said, we're now getting the teams behind some of the manoeuvres that have been known about for decades actually in a regular way within the trust. So I think it's a great step forward. But I just wanted to say, don't worry about that. I think that's a good thing, and I think it's down to the surveillance that's in place now. And there's a bit about IPC, but I'll pick that up in the DIPSI annual report.
Okay, thank you, David.
Thank you, Andy.
Andrew?
Yeah, thanks for that. That's really helpful. And the arts programme, I was just very interested in what you were saying about all of that. I mean, arts sometimes, in my experience in health environments and hospitals, can sometimes look like another box that gets ticked rather than the gold that runs through the whole of the built environment and the detail. And I just wondered how far those conversations, for example, had got with Optiva around the housing and the design of the gardens and all that environment, because I don't think art sits within a box. I think it's part of the whole life and bloodstream of an organisation. So I don't know whether those conversations had happened or not, Jackie, or where you got. Maybe it's been too difficult with COVID, but I don't know.
So I'm going to let Marcine answer that, because Marcine is really such a great drive and help and passionate advocate for this. So Marcine,
you probably won't like my answer, because so far, Andrew, it's been a tick box and it's been a fight, and not a fight. I mean, there's so much going on, so there's no criticism.
No.
You are so right. It has got to be seen as the golden thread. It's not about hanging a picture. It's not about painting a wall. It's the concept of what the environment does to the outcomes for patients.
Yes, that's right, Marcine.
Every conversation we have ought to have that little element. Is what is the environment doing to heal our patients and keep our staff's well-being in check? And that's where I can't say it often enough, and I know I'm annoying, and every time I ask the question, but we're not having those conversations everywhere. And one of the problems is we're not at the table on all those conversations. We're trying, and it's no criticism, and Tom and Suzanne and everybody knows this. It's just we're getting there. And we are reinvigorating, and the teams behind it, we just got to keep talking and moving it forward.
That sounds right to me, Marcy. Keep worrying away at it. Absolutely.
Thanks for that, and great provocative question there, Andrew. That was exactly right. Any other questions, comments? I've got a couple. Jackie, Suzanne first.
I just wanted to say, and I mean, Jackie sort of outlined the case. The grade 4 pressure ulcer I find deeply, well, offensive. might be the word. And slightly to David's point earlier, I think it's really important that we don't enable the team to go looking for all the reasons that happened. We know why that happened, and it isn't because the collar had so I think we just have to be really honest about our assessment of where that care did not meet the requirement. That's and it was all around the bedside. That is where the care did not meet that requirement. And for me, I would say that opportunity to use that as a deep learning moment, a pivotal moment for that team, would be what I would want to know, the opportunity that was being taken there. Because we haven't had one for a really long time, and the team have done so well. So not that I would want them to hear me, say, but it's not acceptable. We're not going to accept it, and we're going to use this thing that happened as an opportunity to keep doing better and looking to our own practice as a multidisciplinary team around that patient or any other. And I think that feels important to say around that particular issue. And
Suzanne, just for the non-clinical, and keeping in mind this is open board, can you describe what a grade 4 means?
Well, it's involvement of the deep tissue. I mean, it's a really unpleasant, painful, awful thing that should never, never happen in our care.
So it's a very serious.
It is a serious thing, and it can lead to implications for the future for a patient, infection can seep in and things. So there are lots of things that can go wrong in our hospitals. That is for sure, and many of them should never happen. And this is one of those things. And when we've done so well, and I just feel it's really important that we don't externalize some of these challenges. In terms of our learning, we do seat it in the right place, and we work with the team to come to the right conclusions, and that we really embed and embrace that learning opportunity. That's the best thing that can happen out of something like this.
Thanks, Suzanne. And just building on that, if I may, because something that jumped out to me was the description of the one on Maple Ward, because somebody was non-concordant with care, declined intervention. And we've heard that this week, haven't we, in terms of the Bronzefield report, where staff sort of say, oh, well, they don't want to engage, and then perhaps didn't follow up. And I'm wondering if this is an example of something where, okay, somebody's declined intervention, but we should keep working on it. I'm just wondering if that's another example of the same sort of thing.
It could be. I mean, I think the unique features of the Bronzefield story do link to the context of that individual. And the question for me is, patients, as long as patients have capacity and we've assessed it and documented it, they can make as many unwise decisions as they like. That's their choice. But as you say, in those conversations, do we fully recognise the vulnerability and the issue for the individual? I mean, that was a young woman in very challenging circumstances, very young. And that would be my sort of challenge to us. Are we really always contextualising why that patient is responding in that way? But it's a really, I mean, David will have a view as the lead clinician in the organisation. It is really difficult when patients elect, for whatever their reasons are, not to follow what is very sensible advice or guidance around their care and treatment. It's a really tricky one.
Yeah. And just moving to Bronzefield, and maybe this is something for the quality committee to take away. We now know we've been properly commissioned, and that we are doing the midwifery services for Bronzefield. but we've not got any visibility of, you know, as non-executives, of kind of how we're doing, keeping in mind, you know, that this is, you know, the vulnerability of the people there. And I wonder if, and we don't need to solve it now, I wonder if the Quality Committee, you know, need a bit more visibility of of how we're doing at Bronzefield.
So it's interesting that you raise that point, Andy, because I think it isn't about Bronzefield. I think there is a learning point out of that very tragic case for us in terms of how do we deliver care to those in custody, full stop,
yes.
whatever kind of custody they're in. And Simon and I had this conversation last night. You know, I mean, Bronzefield is one particular location that we support, but the Young Offenders Institute at Fenton is nearby. That's another group of very vulnerable young people. And so I have already made contact with Jack, because I'm not sure. I think the commissioning is complicated with the prison services through so I think we need to ensure that we understand the whole picture. But I think you're right. I mean, bringing that back through Quality of Care Committee is a really good suggestion, and we absolutely should do that. It might need to come in sort of pathways of care in order to just sort of kind of approach the challenge. But yeah, I mean, we've certainly been reflecting on that this week. And one of the clinicians came directly to David with a sort of a reflection around some of that.
Okay, thank you. And my final point, Jackie, was around viewpoint. And I think I made this point in Quality of Care a while ago now. And it was just that when I was accompanying my daughter in the hospital post an outpatient appointment, I persuaded her to use it. And there was no kind of fast way through it. There were big number of questions, and with the youngsters today, youngsters in particular, but the internet generation kind of want to do things quickly. And I was wondering if we've got kind of a shorter version or shortcuts through it, when somebody just wants to say, yes, it was great and I like this person, you know, that they don't actually have to go through. I mean, it was an enormous number of questions. Yeah, I mean, she wouldn't have done it if I hadn't have been standing there. Put it that way.
So when did you do it, Andy? Just out of interest, to see whether it's changed.
It was about 3 or 4 months ago, maybe 3 or 4 months.
So I'm hoping that because we completely revamped it, we took out all of the long questions, and there are only 4 main questions in there.
Oh, that sounds great.
And then the FFT questions. So there's, you know, it's about our strategic objectives and the FFT. So I would recommend. Well, I'm going to go and test it just to check that it's not as hard as you say, but hopefully it's much smaller. So okay. So if you're passing, do feel free to test it as well, just see what you think. All good feedback, because in the end it's the user interface, isn't it?
Yes.
If we don't get enough feedback, then we can't improve as we would like.
Super, thank you. Anything else for Jackie on the quality report? Okay, in which case we'll move on. And Jane, we've got the Quality of Care minutes.
Yes, thank you. I just thank Jackie for stepping in for Andrea. I think, you know, great work, Jackie. Thank you very much. It's always difficult when you're new, but you done a brilliant job. Thank you very much. And the minutes, the minutes were approved at the last Quality of Care committee. There's nothing particular to comment on them at the moment. If anybody's got any questions, very happy to take them. At the last meeting, we've picked up the main points that we've discussed, and we've agreed to do some work with the divisional reports, because we don't feel they're quite as mature as we would wish them to be. So we have agreed, Jackie and the team are going to link with the divisional leads to work with them, so that we can have we've got some clear data sets that they would wish to report on, but also some key quality information that we would like to see at the committee. And we reflected on the fraud assurance framework, which we will just need to alter in view of the NHS change standard on infection control, which Jackie's picked up. So that's all I wish to say, really.
Okay, thank you, Jane. Any questions for Jane on those minutes? Okay, good. So now we move on to the Director of Infection Protection Control, a well-known Dipsy, David.
Okay, thank you, Andy. So this is the annual report from the 1st of April to the end of March 2021, and it's here for approval and discussion. But it was discussed at length at the Quality of Care Committee, and has also been through the Control of Infection Committee. I think the interesting thing when you look through this report is there's some really good work in here. So we are ranked in the top 10 hospitals for nosocomial transmission rates for COVID. But I suppose that just pointing you to the latest quality report, when we've had a couple of outbreaks, it just points to the fact that there is a lot of infection out there, and actually it's nearly all, in fact I think it's all now the Delta variant, which is now starting to evade the vaccine, and also is hugely transmissible compared to the first waves that we had. And I suppose that it's just, we're only as good as our next week, and actually there's enormous pressures to relax quite a lot of the IPC arrangements in terms of increasing productivity on the elective pathway and throughput on the elective pathway. And there's also a great deal of pressure from patients and relatives who want to visit their loved ones in hospital. So there's a lot of pressure on relaxing things, and we've got to make sure we do know the risks and we take balanced approaches to going through that. The other thing to realise with the infection prevention control, and you're seeing this, that there's now a really great team that we've got in this hospital. It's got much more prominence than it ever did if you went back another year, and also now it's linked up across the whole area, so it's in the community as well, and that's a great step forward. It's got some challenges, but it's got a great step forward, because you see a lot of the infections that are coming through have a community origin for a great deal of them, as well as a hospital impact and sometimes a cause as well. So that's a great move, moving those things together. And the other thing about infection prevention control, it's not just about that team. What you see in this report, which I think is now quite new over the last couple of years, is the breadth of involvement from loads of other teams, the estates, around water quality, air quality. We all know so much about that we didn't know before. The cleaning regimes, the cleaning staff, all those people are central to maintaining good infection control. Now, on the specifics, if you go to table 9, you'll see where we are with some of the common infections that we're dealing with. Further on in the paper, there's quite a lot of graphs which match that table, that initial table on 9 is really benchmarking, or it's setting where we should be heading, and it's usually based on historical data the year before. If you go further in the paper, you will see actually what our infection rates are for 100,000 bed days, and you can see that generally we are doing very well. The areas where I think we can do improvement are MSSA and MRSA, which are both very similar bugs. They've just got different antibiotic sensitivities, but they have the same transmission, and it's usually Lyme related in complex patients on ITU on the wards. So that's an area that we need to do a bit more work. And if you see in the latest quality report, you can see that, as Jackie was pointing to, the E. coli septicemia rates and the Klebsiella rates are a little bit higher, and some of that is due to determination or attribution that's happening in the area. So I think it does paint a good picture. I think it shows that actually the organisation is putting infection control right at its centre. It doesn't mention too much about surgical site infection, but I think that's a really important point that is brought up. And also I think it shows that we need to start treating other hospital-acquired infections like we do with COVID acquired infections, and those are surgical site infections, but hospital-acquired pneumonia and things like that, which are prevalent before and after COVID, and means that we have to adjust our practice for the long term rather than going back to the old way. So you'll see a lot of resistance from me in relaxing some of the measures that are in place. happy to take some questions.
Thank you, David. Jane, anything from the Quality Committee perspective on this paper?
No, I mean, we were pleased with the level of detail in it and how we're benchmarking against our peers. We recognise we haven't hit all of our targets, but we know that it has been an exceptionally challenging year. And I think compared with other acute sites, we've done incredibly well.
Okay, thank you, Jane. And David, in terms of progress towards our North Star, then, what does this tell us?
So I think what we have to hold in mind on the North Star is that the COVID has been really helpful, but it's not the only infection, and hopefully it won't be the most important infection. There are lots of infections, and I think that what it's now alerting us to is we were complacent about infections. We tolerated infections or level of infections in a hospital. And just like Martin, you go on about healing arts, cleanliness and eradicating infection was kind of, I think, downgraded compared to 30, 40, 50 years ago in the NHS. And we've got to really elevate it up. And therefore, although COVID is settling down, I think we've got to recognise that actually it's not about COVID, it's about everything else now. So I think that's what the board needs to keep an eye on.
Okay, thank you. Yeah, maybe is passionate about rather than going on about.
Yeah.
Suzanne.
Yeah, I mean, I was just going to thank David really, because he has really maintained a high degree of passion around this agenda, rightly so. He's a bit of a follower of Florence Nightingale. You may not know that, but this was a lot of the principles are the same. And I think that's why the North Star objective is really important for us to hold on to. And I think I absolutely agree. We were complacent. The beds are too close together. Running departments too hot to get through the patients, and actually tolerating this low level of infection, which for a number of patients, much like pressure ulcers, considered a kind of an inevitable consequence of care. Well, it's not an inevitable consequence of care, and I think we've firmly decided we're not going to tolerate it, but it will give us some challenge, because as David says, we're under enormous pressure from other authorities and patients who are concerned about how long things take and so on. So that's why I think the kind of bringing together of this estates piece and how we organise ourselves, that is the means to get there ultimately, in designing in that infection prevention control safety and routine from the off is so very important. And I mean, we had a little precursor, didn't we, David, with the C. difficile outbreak that we had, norovirus, wasn't it? Just in advance of the first wave, and that did get us on this journey. And I think sustaining it into the future is really important. And yeah, wouldn't it be brilliant if we were the hospital in the country where people said, you know what, I want to have my surgery there because I'm not going to get MSSA, MRSA, C. diff, norovirus, or any other things, because their performance is the best on those things. So that I think the North Star objective is really important to us.
And Suzanne, I love the way you bring up Florence Nightingale here, because actually at the same time, when the Crimean War was on, Queen Victoria was getting lots of bad press, because what was happening was that all the soldiers were dying not from battle wounds but from infection, actually.
Yeah.
And in fact, when Florence Nightingale went to Scutari in Constantinople in 1854, the death rate in her hospital was about 10 times most of the other hospitals. And actually, the ones that solved it, it was about clean water, and it was the engineers. The engineers were the ones that made the biggest difference in the Scutari barracks, actually. So yeah. But it's I mean, I think it is fascinating because it just mirrors so perfectly what we got used to.
Yeah. And even our own hospital, David, the history of Ashford Hospital, when it was an infectious diseases hospital. I don't know if any of you have seen that film, but it's really clear they were very stringent in their approach to the infection prevention control. So it's even in our own legacy. Trip down memory lane there.
And of course, soldiers have always died more from infection than enemy action. It's interesting. Right up to the modern day, anyway. Any other questions for David? I've got a couple of boring typos for you, David, given it's an annual report. And before Marcin says something about them. Criterion 4, I don't think it should say provide suitable and accurate infection on infection. I think that means information on infection. And criterion 5, I think identification of people who are at risk of developing and infection. I think that's probably an infection. But just, I don't know if it goes anywhere else, but if, yeah, just so those are corrected.
Other thing I meant to say, sorry Andy to come in, it was just that obviously in terms of preparation for the public inquiry, these sorts of documents and our North Star objective and all of those elements will be really important. So I think, aside from the harm and the risk to patients and our team, our opportunity to point to some of this work, I think will be really important when the time comes. Just sort of holding on to that future event.
Yeah, thank you for that, Suzanne. Right, if there are no more questions, then we'll move on to the performance section. And Merrick, is there anything you want to say before we give James the floor?
So, no, I mean, I think the key thing is to reflect on the volumes and the volume changes, which the reports here cover. Obviously up to July, but Suzanne's report earlier also talks about the volumes further increasing and getting through backlogs. But that's it. Thank you.
Okay, thank you. James?
Thank you, Chair. I was going to put out slightly less today because we've got a new report and it has been through 2 sub-board committees now. With the quality care and obviously modern healthcare. But the new report will take a little bit of getting used to, but it is a big step forward, we believe. It's using the NHS improvement methodology. This is a guidance that they sent out that, to be honest, we're a little bit behind the curve adopting. We did a lot of benchmarking, and my head of performance, Julian, spent a lot of time looking at reports across the country to get us to this place. So this is an NHS improvement piece of work stemming from work that they call Making Data Count. And it's entirely based on their templates. So my advice on this is to keep page 8, which is the sort of second page of the report, whilst we're novices, which I class myself as. We keep that page 8, keep it printed, and that gives you the variation icons and the assurance icons, of which those pop up through the graphs, and it also gives you the assurance levels. So that's a good key to when you go through the reports. There's nice nuances in this report. As you look at the bottom of each slide, it's got the chapter headings, activity, recovery, RTT, and as you go through the slides, the chapter you're in lights up to tell you where you are. It's also got defined assurance levels. So before we used to describe a level of assurance, and now it's actually there's a definition, an NHS definition that we're using, and we apply to each of our constitutional standards and other areas, which is built into the report. And the whole thing is SPC, apart from 1 or 2 things that we've added ourselves. And also we've added one other box so that we can draw out quality out of this to line up with our North Star and other objectives in our focus. So the set narrative that you get after each chapter is quite concise. So it's very clear about what's driving our current performance, what actions are we taking, when will it be covered, and what's the risk to that plan. That's clear. It has a real concise narrative that's more based around assurance. But also we've added a line, we've added a box around what are the quality implications for the trust, so that we pull out that as we consider each performance against each constitutional standard and what's happening at the moment. So that's a little bit about the report, and I'm sure that we'll all, if there's any feedback, please do give it to us. The last tweak we want to make, which is a subtle one, is just aligning it to CQC domains. But this is, we think we've avoided a lot of teething troubles by a lot of the research we've done and talking to other organisations about their journeys, including the Royal Surrey. So just a few vignettes around where we are. So you can see elector activity we map in here now, because it's such an important part of what we're doing. We're not so much based on the RTT constitutional standards. There's a lot of focus, and as I said earlier in the board, a lot of the focus is around, at the moment, how we performed against a baseline of 2 years ago. So we detail that in the report. We have very comprehensive plans around elective restoration, around all specialties, around insourcing, outsourcing, maximising efficiency, productivity, and using our internal resource. All of those measures appear for all of our specialties. But despite that, August was a challenging month due to annual leave, other factors such as the theatre not being, one of the theatres being knocked out due to a fire a few months ago. So there are a range of factors that we describe here around why our activity was not quite in the place that we wanted for elective work. But you can see, even despite the annual leave that we've referred to in the board so far today, we're still at 110% of outpatient activity. So that's 110% of what we were doing for the same month prior to COVID, so 2 years ago. And that will pick up. We have more plans once the leave subsides, and we have more plans coming online as well. In terms of urgent care, it's a really interesting picture. You can still see how busy we have been over the last few months. Slightly less busy over August, but we're still higher attendance. So it's 317 attendance averaging in August compared to, I think it's 300 2 years ago. So we're still busier than pre-COVID. The surges are still there in the evenings particularly, and you can just see the volume of activity that we've had over the summer months. The summer has been busier than any winter on record, any other set of 3 months on record. So April, May and June were our busiest in terms of attendances to our urgent care facilities. You can see our performance, so comparatively, we're performing comparatively pretty well against the rest of the region. So everywhere in England has these challenges, and we're performing pretty well against that, against the rest of England. In terms of elective activity, whilst our elective activity was a little bit lower than we wanted to, our outcomes where we're achieving are still good. In terms of, we are targeting the right patients, we're doing a lot of work around chronological booking, and that is coming through against all the standards that I've worked through with the board before, over 90 weeks, over 78 weeks, over a year. You see that those parameters are coming down. So we are targeting the right patients. Also, our patients, our P2, these are patients who need an urgent operation, which is classified in 4 weeks. The number of patients waiting over 4 weeks is consistently coming down. So we are targeting our urgent patients and our longest waiting patients. There was just one thing around outpatients that we drew on in the quality board, was just around, whilst we are trying really hard to increase activity, our number of outpatients, urgent outpatients waiting over 6 weeks is still high compared to pre-COVID. It's about 1,500 patients over 6 weeks for an urgent appointment. And we detail in the report the number of people with an overdue follow-up. So need a follow-up and it's past the date that was required. Pre-COVID, we were running around 2,000 patients, 2.5, slightly more on occasion. We've now been running around 10,000 appointments that are overdue. So we have detailed that in the report too. Overall, though, diagnostics is improving. It's a good picture in the diagnostic activity. We had some challenge over the summer with sickness and annual leave generally, which gave a bit of a problem through MR and non-obstetric ultrasound, which you'll see in the figures. And also our endoscopy, we've continued to make improvement, although we're challenged. We do have ongoing challenge in there that we detail. I think I'll leave it there and take questions, Andy, if that's okay. It's a new report. There's a little bit to get your head around, but I assure you, once you do, it's really fascinating. In terms of SPC, it's really, really transparent about where we are and the progress we're making. And you know, is it progress? Is it one-off? Is it a trend? Yeah, it's really helpful like that. It's a more assuring board report.
Okay, thank you. And I would agree with SPC charts are definitely a very, very good way of doing that. So, Marcine.
Thanks. I obviously missed Modern Healthcare last week, so this is the first time I've seen this. And maybe you're right. I'll get my head around it. I found it really hard. But I'll work on that. Where can I see the old chart we had, which showed the UTC versus the adults versus peds A&E, and just because we won't have a meeting now till November, given the new unit opened on the 26th of August, have you seen better performance for September with your flow? So
yeah. So what we haven't done is broken out those areas, Marcin. We've tried to, I mean, we're at 29 pages, so we can take feedback from the sub-board committees, but we've broken down here for our performance into the two standards that we report on externally and the two types of performance. So we report externally on the NHSI position and the St Peter's site only position. We've broken both of here, and the admitted and non-admitted, which, you know, the non-admitted is UEC predominantly with our walk-ins. So you can sort of get a feel for it from the graphs that we have provided, but we haven't provided those exact breakdowns just because of what we're encouraged to do with this template, but we continue to take feedback on it. In terms of activity since as we've opened the UEC, it has been tough times, and it's quite hard to define some of that because we have been helping out other organisations as well. So we've got it's been publicised, you know, it's well known that one of the hospitals in Surrey has been in business continuity for the last week because of the volume of activity, amongst other things. And we've supported them on occasion. It has been busy. So we're running about the same level of performance that we were, but it's probably made us a bit more resilient, to be honest, given the challenges that lots of people have experienced during August, September. Been high annual leave, high staff absence, for a variety of reasons. That's provided quite a lot of challenge. And I think what we are seeing in the first few weeks is increased resilience, to be honest. I don't know if
okay.
Yeah. Thanks, Marcin.
Other questions? And you're right, James, both the quality of care and the modern healthcare can feed back on the detail. Anything they want to see, but I mean, clearly we have to, the ones we focusing on are the national reporting standards here.
Yeah, that's exactly what we focused on here, is being very open with the board around this stuff that gets reported externally that you might see elsewhere in the public domain. We share.
Although,
and the key performance or quality considerations.
Although, of course, because we subcontract the UTC, we are interested in the performance of the UTC, for example.
Yeah, and that's in the number that we report externally. In the footprint number.
Okay. Any other questions for James? No, I don't think there are, James, at the moment. And I think, you know, Marcin's right. We will take a while to get used to this because it's such a different format. And certainly when you showed it me, I thought, wow, but good advice in that print off page 8. Definitely print off that page because you need that by your side when you're looking at these graphs for the first time.
Yeah. Yeah, and I say there's quite a lot of supporting literature that we have shared to the board and other committees that we can continue to do. So there's a Making Data Count whole pack of supporting materials that come to support boards around this that we can share.
Merrick.
Yeah, sorry, actually, as you say, like Marcin, even after having looked at the report first time last week, it's going to take a while. The volume of patients in total, in all forms, both, you know, elective activity, investigative activities, and so on. Where would I look in this report for that? Because to some extent, these graphs show where we are in relative performance. They don't really go back to, for instance, something that we picked up in July, and as in Suzanne's report around, you know, the UTC peaking at 365. We see that volume there. But what was our base level of operating capability, because otherwise we end up saying, well, if we're working at double the capacity that we've actually got a designed staff and physical unit for, we kind of need to be reminded of that. Yeah.
So I'm with you, mate. I'm just wondering how we would keep cutting it to show all
well,
of these variants.
Well, I know we have to work with these graphs, but the two things that have stood out to me in recent meetings that we've had are, I think you quoted, it will have changed now, 15,000 people waiting some form of attention in a hospital, correct? That was in the July board minutes, and that's a big number, and there's nothing in here that attests to it. And then again, we touched on in the July minutes saying that our UTC capacity was 150. We were, well over 200, and of course now peaking at 365. Otherwise, we just delude ourselves.
We're mixing metrics there, Merrick. So the your quote 365 is the total attendances throughout urgent care facilities through UTC and all components of A&E. So it will be higher than the attendances through UTC are one issue. The 365 is attendances through UTC, minors, paediatrics, ambulatory care, all of the channels in.
So how do we determine what our capacity is so we can judge how we're doing against our capacity?
Well, we have the run rates in here. So we've got the capacity, we've got the activity compared to, which is what we report externally. So what we report is how, at the moment, we are required to report to NHSI the whole of our financial basis based on what are we doing now compared to 2019 pre-COVID year, the same months, which is what we've got in here, because that's what we're reporting externally. So that is on page 10. So we've got that for elective outpatients and outpatient procedures. So you can see what we're doing now compared to pre-COVID.
Yeah, something I guess that we'll get into more in the subcommittee as we work our way through this report.
I think, and 1,000 patients waiting for treatment. We can, the size of the RTT list is, I think, what we were referring to. But we have
that
just
is in there actually. I've just
it is in there. We have just over 31,000 patients waiting for some form of treatment.
Okay, thank you.
Okay, thanks. I see Chris is having problems getting back in. I've been trying to admit him, but it keeps saying action failed. So Bill Gates strikes again. All right, thank you for that, James. So we now Merrick, the modern healthcare.
Well, we've covered all of the dare I say, the volumetric aspects and the work upticks. I think the only thing I want to say is we are really awaiting to see what the funding will be in the second half, and I think that we have to anticipate there will be a significant shortfall in the funding against the operational levels that we're running at.
I think that's absolutely right. That's true. Okay, thank you. So Dami was going to do the people minutes, but Louise, are you going to pick those up for her?
Yeah, happy to.
Can I just comment first?
Andy, David.
Oh, David, yeah, sorry, I didn't see your hand up there.
Yeah, I suppose I was just drawing attention to that previous conversation about activity and performance and demand or whatever, and I suppose all of us in exec, we've been kind of what we need to do is arrange ourselves to meet demand, and I think that the metrics that have been put in place they don't really clear all the noise out the way. I think what it points to, the fact is there is unprecedented demand, and what we have to do is we have to organise ourselves in a very different way, and we're doing that a bit internally. But I suppose the discussion we were just having was all internally, and actually it goes to this strategic discussion: is how as a system can we solve the problem? And we've got to start bringing that conversation into the internal one. Otherwise, we don't change the world, as it were. So,
yeah,
I suppose it's a slightly naive point, but I just think Anyway, we've got to connect them up really because they're disconnected.
Yeah, thank you. Not naive, it's essential.
Correct.
Sorry, so Louise, back to you.
Thank you, Chair. So these are the minutes from July, and I suppose a few highlights from the minutes. We tried to bring an item to each of the People Committee, setting out the progress that we're making with the Workforce Transformation Programme. And in July, we updated the committee on the fairly extensive diagnostic work that we've been doing in terms of flexible working. We know that flexible working is a key part of the National People Plan. They believe that there are opportunities for us to significantly increase both retention and attraction of new talent into the NHS if we are able to be a more flexible and dynamic employer. So we are, a part of the Workforce Transformation Programme is to look at where we get that right, and also to look at where we've got opportunities to improve that, and a fairly detailed report to the People Committee setting out each divisional sort of position and aspiration in terms of moving this piece forward. And obviously part of that is our implementation of RotaGeek, which is our new rostering system, and we will be starting the process quite soon to ask one of our nursing teams to pilot a self-rostering system as part of the implementation of that. So that's all really good stuff. The People Committee also received the regular workforce report that we try to present against the risks in the board assurance framework. In particular, quite a lot of conversation around our planning for winter, and in particular what we're doing in relation to paediatrics, around RSV, and at the time the potential concern around delivery of the elective target, given the consequences of Surrey Safecare. Obviously, since then, those things have changed slightly in terms of timetabling. We received the report from the steering group for equality, diversity and inclusion, and in particular we looked at the RES Workforce Race Equality Scheme, Disability Equality Scheme and Gender Pay Gap submissions, and they've recently gone through a number of governance meetings as part of the process for reviewing those. And we looked at our annual report to understand activity and whether or not that was against the terms of reference that we'd set. We had quite a long, we always have quite a long conversation about the BAF, and whether or not we think that we need to do an adjustment of the BAF based on the conversation and the narrative that we receive around people. And Andy, I think it was yourself, suggested that we needed to think about a new strategic risk around resilience, and that won't be a surprise to you given the conversations that we've had already today, and Suzanne illuminates that quite significantly in her chief exec report. So that has now been done. We've presented a draft of what that could look like to the September People Committee, and we're just seeking feedback from the committee members as to whether we've got that right. So that's the sort of update from the July People Committee. Andy.
Thank you, Louise. So any comments on the minutes before we move on to the terms of reference? Okay. All right. So terms of reference, I think they're self-evident. They're highlighted, the bits that have changed, haven't they? So
yeah, not really anything particular to highlight apart from what we've already written in the executive summary.
Okay. So are we happy to endorse those terms of reference? Yeah, I'm seeing nods. Yes, good. Okay, so they're agreed. Thank you, Louise. Sounds like there's a train in the background somewhere. I think that might be Chris.
Me.
Actually, I think it was Louise. Which is okay. So we're going to move on now to the Equality Annual Report, and that's back to you, Louise.
Yeah, I think Suzanne's going to just take a moment to do a quick introduction of this.
Okay, thank you.
Thanks, Andy. So this is our annual equality report, and I suppose in many ways this report, we've had to do this for some time. What I would say is our approach to it is strengthening and deepening, as is our understanding, but we're not all the way there yet. And so in some ways the report is a collation of work that we've done, and clearly it's been set within the context of the response to the pandemic, and clearly, you know, whether that was, you know, people in the community or our own teams, what we know is that revealed the stark inequalities in our society, but also within the risk that brought to different members of our team, and we had to pay very close attention to that. But in a way, I suppose that gave rise to an opportunity to strengthen our relationships with the networks that operate within our organisation, and start to spend more time with them in terms of developing our insight and having conversations, which I think has been really important. I think it's helped us to actually bring them together. So they often sort of operate the networks in silos from one another, when actually the drivers to their experience are quite often shared, and the solutions are quite often something to be shared and learnt from. And we've encouraged them to work collaboratively. And I think that, you know, so lots has been done and lots of discussions have taken place. Question remains, have we moved the dial on the experience for all of our colleagues, and have we moved the dial on the health inequalities that we see for our patients? And I think I would say, well, it's nudging gently in small steps, but possibly we need to move it faster. We also need to challenge ourselves around how we think about some of this. You know, the kind of perceived gender inequalities or racial inequalities aren't always revealed in our workforce data. And so we have to make sure we're paying attention to the right challenges that sit within our organisation. And the sort of the famous one for us is, you know, there's a lot of discussion about it, you know, the challenges that some of our medical colleagues might have in securing leadership positions, but nobody ever talks about the inequality in the nursing fraternity for our male colleagues, and that is something that is very clear in our data and we need to pay attention to. For example, it's just one example. We've got more work to do around disability in order to understand what that looks like for colleagues, and even the extent to which we've got members of the team who have a disability, because often they don't declare, and there must be a reason for that, and we need to understand what that reason is and address it. Our data collection is quite poor, and you know, we need to understand, well, how do you collect that data in a way that colleagues feel comfortable with in order to inform decision making. So in many ways this is about continuing the conversation, I feel, developing mutual understanding. This isn't around any particular group, it's a shared sense of understanding. So I draw it back to the kind of approach we're strengthening around an inclusive culture, you know, where there's a sense of belonging for everybody, where there's equity and of opportunity for everybody, rather than pursuing any particular line, but it's about that shared understanding and mutual respect. So that's how I feel about it, and that's how I've gone about leading our steering group around it. And I would say I'm learning every day. Every day. I've enjoyed the allyship programme, but I have found it really challenging my own values, really challenging to my own biases. And that's hard, actually. So I would really encourage everybody to engage in one of these allyship programs, but it's not easy work, I would say. But Louise and her team have done an enormous amount of detail, and the People Committee has played an important part, I would say. So I'll pass to Louise for the detail. Hopefully that was a useful introduction.
Yes, thank you, Suzanne. And to be honest, the report in itself is quite detailed, so I'm probably not going to take people through that page by page, but just some summary really in terms of the progress that we've made. So I guess a number of years ago, I would have been sitting here talking to you about there being a differential between our white and our non-white colleagues in terms of going through the employee relations process, and that gap has now definitely narrowed, so that's really good to see. There isn't a differential anymore. You aren't more likely to be going through a disciplinary process if you come from an ethnic minority than if you come from a white background, from the data that we see here, and that has been, I suppose, a progress that we've sustained for a few years. There is still more to do in terms of a differential in relation to where people are appointed in the organisation and people's opportunity to progress in terms of senior roles. And the report does give you a few examples in relation to that, but actually much more that we need to do. We've set up a recruitment and promotion working group where we have representatives from our management teams, but also representatives from the networks, to look at the opportunities for us to improve our recruitment practices, but also improve the opportunities for us to be identifying where talent is, but where talent doesn't seem to be coming through. And if Andrew was here, she'd talk about the work that they're doing in terms of mentoring to try to ensure that we are increasing the diversity within her matron and her senior structure. As Suzanne said, our data around disability shows, again, that you are less likely to be employed if you have a disability from application than if you are non-disabled. We talked about this at the People Committee, and actually since then, one of the observations was the data around recruitment, which actually was incorrect. So we've gone back and had another look at that. We've reworked our data, and actually the difference is less, but there still is a difference. So the work that we've been doing with our managers to get them to really understand, how do I change a job to make it more accessible for other people, has been useful, and we will need to continue on that education journey. I think the other thing to say, Suzanne, which I'm not sure you mentioned, was the piece around inequalities for our patients. And obviously, when we talk about equality, diversity and inclusion, and when we present the annual report, we do spend a significant amount of time focusing on our workforce, but our ambitions are also to create an opportunity to address inequality in our communities, ensuring that people have equity of access and the best possible healthcare, regardless of any of the particular protected characteristics or background or opportunity to access healthcare. And we're working hard to create the opportunity to look at that within the Equality, Diversity and Inclusion Steering Group. And there is some detail in the report about the work that we've done to look at mortality rates and stillbirth. So it's not very much more that I'm proposing to present, Andy, but I'm happy to take any questions.
Okay, thank you, Louise. Questions for Louise? David.
Yeah, I'm Louise. I think it's a fantastic report, but like always, there's more and more that we need to do. And I think the thing you're pointing to is we've got to understand our community as well. And we've got to understand the makeup of the community and how that differs from the community within the hospital. And I suppose what I thought was missing from the report was deprivation and things like that. We need to understand what that looks like across the piece, because the community and our community are very different in many ways. And actually there's different communities within all of this. And we need to understand the equity and fairness within all those things and try and understand it and understand how we've come to such different variation in all those groups. And it's a complex picture in the NHS, isn't it? It's a complex picture about education, about recruitment, and about how we've employed people. And we need to understand that. So it's a really complex picture. And I think the other bit that I think is really good, Louise, is we've got to bust the myth on some of the narrative that's out there, which is clearly not borne out by the data, and we've got to challenge it. You know, the medical profession is, you know, the issue in the medical profession in the hospital is about men and women. That's the disparity. It's not about ethnic minority groups or leaderships or things like that. It's different, but it's different in all the different groups in the communities, and we really need to be. I mean, I think Suzanne, you summed it up. The more we look at it, the more we understand how we understand about it. So I think it's a great report, Louise.
Andrew.
Yes, I mean, the only thing I'd say about it is that this, building on David's point, this is a complicated area. And I worry myself a lot about the ability of the civil service and the processes of government to put people simplistically in boxes, because human beings are very complicated with complicated histories. And actually we end up, if we're not careful, judging people by the colour of their skin, their gender, whatever. And I know from experience that it's a bit more complicated than that. And you remember, indeed, in the early days of Bromley by Bow, Ethel Wheatley, an East End grandmother, was 73 in her body, but she was actually 17 in her head. And that actually I've come across young people who are quite old fashioned, but they're only 16. i.e. this compartmentalization of human beings, I think, has many unintended consequences as well. And many years ago in Bromley by Bow, we decided not to go down this route, as a matter of fact. And indeed, I've just sat through a Valuing Everyone seminar. Some of us have had to, you may have read some of it in the press, in the House of Lords, actually. Some very senior people, including the head of the Human Rights Commission, etc. We thought it was extremely naive, actually. And so I'm not saying this is, I'm just saying there is a discussion here to be had about complexity of human life, because the other danger of some of this compartmentalization is you lose the real creative potential of human beings if you compartmentalize them. You can't deal with it in a discussion at a brief board like this, but I just share with you the thought, beware of unintended consequences and losing the real potential of human life.
Thanks, Andrew. Thank you. Any other questions for Louise? Chris.
Just a very quick one, actually. I've sent you the email link, Louise. I mean, this is a topic, I thought it was excellent, by the way, and it's a journey, isn't it, in understanding. And it's a hot topic in political circles. And I've just seen that NHS providers want to pull a survey together on race and health inequalities, and I just forwarded that to you because I, particularly as a NED, they're asking NEDs. I don't feel particularly qualified that I can answer what they're asking. I think this is something at board we have to sort of almost do together and come to a view on. Anyway, I've just shared that with you, and I'll be interested in what you think. But it is, you know, it's a journey, isn't it? That's my point, really.
Thanks, Chris.
Louise, I was going to ask about your Overseas Nurses Forum, because I think that's very useful for retention, for listening to obviously people who've uprooted themselves from their culture, from their families, and of course have stayed away from their families probably much more than they were planning to because of COVID and restrictions and red lists and all the rest of it. So is that now growing? Is that a strong thing? And do you attend, or do your team attend? How does that work?
It's run by Ellen, the deputy chief nurse, and some of a number of my team do support her with that. And I think in the report it just points to it that forum having met a few times, but obviously that was within the reporting cycle of the report. So yes, it is something that, as I understand it, is an ongoing forum that people find really useful, and is a really good opportunity for us to engage with a part of the organisation. As you say, Andy, you know, there is a potential for them to become quite disengaged if we're not proactive with that. Yeah, I mean, we can maybe ask Ellen some more questions in relation to that at the People Committee.
Yeah, I think that would be good, because most of us, you know, just haven't had that experience of being uprooted, put in a different culture, completely, you know, divorced from family for much longer than we'd thought, and all the rest of it. So the more we can look after them, the more we should, really. Jane.
Thank you. It's just really picking up the page 9 about mentoring. I'm just really interested that I see that we have launched the BAME mentoring program, which has obviously been very positively received. But picking up other groups that might need support, such as those with disabilities or those with maybe different needs. I'm just wondering, are we going to focus on doing different mentorings for different groups, or are we just going to make mentoring more inclusive in the round, so that actually, you know, it's mentoring is seen as for everybody, rather than having to put it for specific groups? I just wondered what the forward plan is, really.
Yeah, I think this is a particular mentoring scheme around encouraging people to think about career progression. I think it's not the only mentoring scheme that we've got in place across the organisation. We've just launched and are looking for interested parties to join a disability network and wellbeing group. So the focus with that group is to bring together colleagues whose opportunities within the organisation and experience of working in the organisation may not be as good as others, and that has an impact mostly on physical well-being, but also to look at whether or not there are access to promotion opportunities for that group as well. So I think, as Andy says in his introduction, he's looking forward to, you know, sort of being able to demonstrate our focus on other groups, and in particular that piece around supporting our colleagues who have a disability, and in improving the opportunities for people to come and work in the organisation. So yes, I suppose I'm not really answering your question, Jane, but certainly mentoring schemes are in place across the organisation, but there was a particular focus for this piece and reason for adding it to the report.
Okay, thank you.
Okay, I think I'm going to have to bring that, keeping an eye on the time, to a halt there. But I think the summary is very good report. We are progressing, and there's lots more to do. And I do listen to Andrew and his, you know, the dangers of putting people into little boxes when, you know, we're all individuals actually. So we just do need to be careful. I think just keep our eyes open. But certainly the allyship training that I did was good. I'm not sure what the next stage of that is, having been on one meeting, but I'd be sort of keen to carry that on. I think that's really good. And certainly if any of the other non-executives want to do any of that, then I would encourage them to do so. Okay, so we move on to the medical appraisal and revalidation, the annual report. David.
Thank you. So this is the annual report, and it's covering the year up until 31st of March of this year. It's already been discussed at the People Committee. It is here for approval, and it's approval around the compliance statement. So I think Andy and Suzanne, you have to be able to sign that at the end of that. So I think essentially, I mean, clearly this year was a different year. And in fact, appraisal and revalidation was suspended by the GMC throughout this time, although we did encourage people during this time to at least have a health and wellbeing appraisal, and also quite a lot of people, so about 95 of our doctors still went ahead and got an appraisal. So I think that is that's it. I think if you go through the bit, I think that we are delivering all the parts that people say that we should do with regard to appraisal. I think the system that's in place is functioning very well. you can see the list of people who went through appraisal and the ones who deferred for various reasons, which are stipulated. And there's a very good process now about working out what the reasons are if people aren't going to have an appraisal on time, or if they're not going to be revalidated on time. And that's certainly a big improvement from a few years ago. So, I mean, I think I'll take the report as read, but I'm happy to answer some specific questions. I think, Marcin, you had some questions, didn't you?
Yeah, I was going to say that Marcin, in her old hat as chair of the People Committee, has kind of got a point on point 4, I think, that is worthy of discussion. Marcin.
Thank you, Chairman, and thank you, David. And apologies that I wasn't at the People Committee who approved this, but I say from my experience that the statement in 4 is a bit overstated in terms of what we get. And we might think about going forward whether the report needs to change at People Committee, but we don't get numbers, types, and outcomes of concerns around doctors' performance. We simply get a number that says there's a couple from bank under investigation. So I just think it felt to me that for us to sign this off with a statement that the People Committee gets the assurance is a bit of an overstatement, and what we get is a bit more generic. And if you feel that this is something that we need to have to comply, then I feel that we should develop the report going forward in People Committee.
Okay, so I suppose, and Louise may want to answer. I mean, I think you are at the People Committee. You are given indications of the numbers of doctors who are going through various processes, and there's a collection of different processes that doctors go through. There's the GMC processes where, in fact, any doctor can be referred to the GMC by practically anyone, and an investigation is either then continued by the GMC or refer through us. And so you get a list of all those things. The question we've got to ask ourselves is I think you do get the numbers in the report. I think there is on number of people who have an MHPS investigations, number of people who have been referred to GMC, and those are MHPS processes are either capability or conduct. So that covers all those processes. I suppose we do need a debate here about what I can share with you about the individual cases, and what extra information would give you assurance. But there are some things that I can't because of the manner of the process. So okay. I think we need to do, what we need to understand, Marcin, and maybe.
That's fine, David. I accept that we do get numbers on those categories, but it says here the analysis includes numbers, type, and outcomes, and the protected characteristics. Now we don't get that. And if you feel that's not relevant for us to get, absolutely understand that. Yeah. And that should be stated in terms of how you manage that control and that process. Yeah. What I don't like is when we say we get something that we don't. I'm one of those open people. Yeah.
No, it's a fair challenge. And what I'll do is I'll talk to Louise. I mean, maybe we'll talk and see if we do need to give more detail about the demographics of those individuals.
And I think it's fine that we can. You talk to Louise, David, bring it back to the People Committee for the going forward. But I think the issue is we can't sign it as it's currently drafted. So we just need to be careful about how it's drafted. I mean, receives a bi-monthly report on all employee relations cases. Yes, including those pertaining to doctors. Yes, maybe we drop that with the above information. And then maybe there's an action for next year that sort of says that we will look at the appropriate level of detail to be made available to the People Committee. And then that would, if you're happy with that, David, then that would, I think, address Marcin's concern and mine, actually, because I'm signing this.
Yeah, I mean, the format of the report is laid out to us, but I agree we can do, but the boxes we can change, as it were.
Yes.
Yeah. So
I would suggest changing it along those lines. Marcin, are you happy with that?
I would be content with that.
Louise?
Yeah, it was just to say 2 points. Possibly non-executive members that weren't aware that when we talk about MHPS, that is only doctors. So that doesn't include any other staff group. And we do, if you refer back to a report, you will see that we do a trend line for numbers of MHPS cases, and then further detail in terms of whether or not they've included any kind of restrictions and whether there's been any referrals to the GMC. I suppose the other thing is we also do provide some data in terms of analysis of protected characteristics. So if you look at the report that was in September, we did some commentary on capability. Now that would be for all staff, and we were able to look at the number of people that were going through a capability process who were disabled or not disabled, and we also identified people by their ethnicity. What we didn't do is then triangulate that with staff group and have that all comprehensively in one chart. And some of this is about our capacity to do that, and we spend an awful lot of time producing data and analysing that data. So happy to go away and look at that and discuss with the people committee to check if the level of detail is specific enough. But we do provide all of those things in some shape or form. It might just not be as comprehensive as the question in the medical revalidation paper was asking.
Yes, I think that's right. So I think the way forward for the report is clear. We'll just redraft the comment box and perhaps consider the actions for next year, just to say that we're looking again at the level of detail, I think, and then we'll with that change, I think as the board happy to sign this report off. Okay. Thank you. Moving on, Surrey Safe Care verbal update. Obviously, we've had one of those in closed board. Simon, do you want to just give us a quick overview, please, for the open board?
I guess it's mainly around the new timelines that are of interest. We've got some build work that we've got to finish by the 15th of October. The period up until Christmas were largely into testing, trial loads, and those sort of processes. The training of all our clinical teams will begin in mid-December and run through to the end of March, and then we're aiming for go live end of February really for the training, and we're aiming for go live on the 7th of March. So yeah, it's a new timeline. It's an exciting one. We're undertaking obviously additional work and corrections to the previous issues that we faced, but we're we should be able to deliver that new timeline really. So and that's the same timeline for both trusts, I should say, both Royal Surrey and ourselves.
Yeah. Okay. And Suzanne's mentioned that as well. Chris, have you got anything to add?
No, not really. I mean, we did mention it under Suzanne's report in terms of those actions. So yeah, I think that's fine. Okay.
So I think it may be a blessing in disguise, actually not doing it in December, given the likely winter pressures, and we've got a bit more time to think about it. So certainly in terms of operational deployment, I think it should be easier. Financially, of course, it has its implications. Okay, thank you. I'm going to move on now to regulatory. Simon, the inevitable trust seal.
Yeah, we just used it twice during September. The first one was just around the contracts on Elliot Ward in the main, also some of the smaller pharmacy works, but the current pieces of work that have been undertaken in Ashford, or estates work, sorry. And the second one was around the Berkshire and Surrey Pathology Service and the introduction of SASH into the partnership. So it was just really formalising previous business cases that the Trust Board has already seen, really. So just for noting those.
Okay, thank you. Okay, noted. And we then move on to the Marcin with your Audit and Risk Committee terms of reference.
Thank you, Chairman. As I mentioned to you before we get on to this, 2 points of business from the Audit and Risk Committee that the board should be aware of. One was that we finally signed off the audit in September after the auditors concluded their VFM arrangement. They had no recommendations and no findings, which is excellent, and therefore we could complete the audit. It was due to be laid before Parliament on the 17th of September. However, Mr. Lord Mawson, the Lords went on recess without letting the rest of Whitehall know, and therefore there was mass confusion and we were unable to lay our accounts. All going well, we will lay our accounts before Parliament on the 18th of October. So thank you for that. Poor Sal went through hell in the backwater to get it all done, and then it couldn't be laid. But it's all done, clean opinion, all sorted, and we're now moving on to procuring new auditors. No more said. Now, our next thing I think you should be aware of is that we're participating, rightly so, in a national fraud exercise on COVID procurement. We don't have any output from that, which is quite interesting that I got told last night we're not going to hear anything until March. So how it's relevant, I don't know, but it's good that we're participating. Simon assures me that we will find nothing in our closet. So that's exciting news, and I'll keep you up to date. But on to the most exciting agenda item of today. Just joking. I'm thrilled to be taking over Audit Committee. It is my 33 years of background, and I really wanted to make sure that we were best practice. We have been going for gold in terms of outstanding, well-led governance. This is the final, not one of the final pieces, but this is a piece that actually we need to do. We need to be seen to be doing the best in terms of good governance and reporting. So my changes, although you might seem they'd be onerous, they won't be. They're really just making sure that we are ticking those T's and crossing those I's and getting the right things in front of us. So the main changes that affect all of my executive colleagues and my board colleagues is really your participation in ensuring that you've got good oversight on the internal audit reports. Before they've come to Audit Committee with no information about what the exec or the non-exec feel about the report. And we haven't been getting anything but limited or moderate assurance. And I'd like to see us in the non-financial areas getting more better assurance. And this way we're taking a little bit more ownership, making sure that we've got realistic recommendations and realistic implementation. We have been actually in the past few years very faulty in implementing the recommendations, mainly because probably we hadn't really understand their implications. But it does have reputational issues for us, and so I'm trying to tighten up our approach. And the other areas is actually making sure that we're looking at all the key internal control areas. And you might say, well, what's Audit Committee got to do with clinical audit? Nothing, other than making sure that we're doing clinical audit. It's got an overview, it's got an oversight, we understand why, and the processes around internal controls. I've spoken with Jane, and from my own experience of sitting on the the quality committee, we only see as a list what the divisions are involved in, but we don't really get a sense of the overall picture, the resources going into it, the controls around it, and the outcomes. So this is really an annual approach, and it's something that David, Andrea, Jane, and I need to meet and talk about how we'll make this work, so that it's not onerous, but it's just adding to good governance. And that's all I'm about. And I'm hopefully you'll support me in what I'm trying to achieve. And the last thing is that Andy doesn't ever come to our Audit Committee, rightly so as a member, but once a year he ought to come and ask us how we're doing. And so it's getting Andy there and having him a chance to grill us on our effectiveness for ensuring internal controls at this organization. I hope you agree.
Thank you, Marcin. And I think, yes, I would agree that yourself, David, Andrea, Jane need to get together and just agree the how of this without adding to the burden of the execs. Okay, so any questions on these terms of reference?
You're all stunned into silence and you can't wait to attend. We've got a schedule for all of you chairs and execs to come, and I can't wait to see you. So you will be presenting your BAFs and your response to internal audit, and Paul and Simon, we will be in touch with you. Looking forward to it.
So Suzanne.
I was going to say, Marcin, it's clearly going to be the best sub-board committee ever. I'm like a coiled spring. Can't wait.
And it's nice to be invited, Marcin. Thank you.
Oh yeah.
From my perspective.
Simon's sorry, Simon.
Simon's just getting the
just
new
struggling with the mute button. It wasn't deliberate, that pause. Of course, Marcin, it's fine, no problem.
Right. Okay. Agreed, Marcin. Thank you.
Thank you.
Okay. So, any other business?
David, did we approve the DIPSI report?
I did ask that, yeah.
We did.
Well, I'm not sure we did formally. I'm not sure you said you approved it.
Well, did I not? That's because it says receive on the agenda, not approve.
Yeah, I think it's got receive and approve. I think it's for approval.
Yes. So I think isn't that we said with that one thing? Yes. Approved.
Yes.
Okay.
Unless anybody says otherwise.
There's just 2 typos that needed to be corrected.
Yeah.
Those typos, yes. I thought we did say approve that. Okay.
All right. Maybe I missed it.
Yeah. Yes, because I said with apart from those typos. Definitely. Right. Anything else? We're looking forward, I think, in the next period to the opening of the Wellbeing Centre. That's very exciting, and I know there's plans afoot for a formal opening, etc. So we'll look forward to that. Okay, so moving on. Finally, Liz, have we had any questions from the public?
No, we haven't. We did receive some, but it was too late in the day. It was late yesterday evening.
Yes, and I did see one of them was around physio in the community.
Yeah.
We actually have addressed that.
Yes.
So we now have Egham Orbit, the Chertsey, Riverbourne and Woking all up and running. So I think that's very exciting stuff. We can address the other question in due course. Okay. So we're 13:22. A good meeting, I think, for in public. Anybody got any reflections on it they'd like to share? I do think that Suzanne's new report is going from kind of strength to strength. Actually, I think that really helps bring things together in terms of risks, etc., for us to look at. And we look at them in the individual committees, but that actually is developing really well. And I know Sal's been helping you with that as well. So thank you.
More than helping.
Sal. She's still got some hair left, so that's good. Okay, so look, the next meeting is the 2nd of December. We hope we'll be face to face, but we haven't got the venue yet. We will advise you on that.
And we hope we have fuel.
Yes, hopefully we'll have some fuel as well. So I think the next meeting, Sal, is 2 o'clock for strategic change, but I'll draw this meeting to a close. Thank you very much.
Well done. See you at 2 o'clock.
Thank you, Andy. Thank you, everybody.
Bye. Bye.
Bye.
See you shortly.